Hello, go ahead. We can hear you.
Go
Yeah,
ahead, we
yeah,
are
we hear
hearing you.
So, for instance, for HER2 positive breast cancers, if you do neoadjuvant chemo, 8 cycles, usually if you're starting with the anthracycline-based regimen, either doxorubicin cyclophosphamide or epirubicin cyclophosphamide, 4 cycles, then you do docetaxel carboplatin, 4 cycles, that's 8 cycles. Then you do surgery, that's for patients with T2 staging, above T2 staging. After the 8 cycles, you do surgery. If you achieve PCR, remember when you are doing docetaxel cyclophosphamide, you will add the targeted therapies. Yesterday I was telling us why you don't combine itracycline with the targeted therapy, trastuzumab and pertuzumab, because both are cardiotoxic. So when you are giving doxycycline, you don't give it the same time concurrently with the targeted therapy. You do it sequentially. So you have to finish the 4 cycles of AC or EC before you can now introduce targeted therapy. But you can give targeted therapy with docetaxel or paclitaxel, carboplatin, because they are not cardiotoxic. So you can comfortably combine them with trastuzumab, pertuzumab. So the targeted therapies are also given as neoadjuvant therapy. So when you complete the 8 cycles, you do surgery. If you achieve PCR, you will continue with the first line targeted therapy, that's trastuzumab, pertuzumab. You complete the 8 cycles if the patient is stage 2, 3. But if the patient is stage 4, is lifelong treatment till disease progression. If the patient is stage 2, 3, the patient will only do 18 cycles. But if you did not achieve pathological complete response, at this point after surgery, the patient's treatment will be changed to advanced blockade. That's the antibody drug conjugate I spoke about yesterday, the ADC. In this case, you will use trastuzumab and tansine, that's Kadcyla, and you will do another 14 cycles. So you've seen the treatment algorithm because you chose the right treatment plan from the beginning. You didn't jump to do surgery, you did neoadjuvant. And most of the patients that were treated with this right treatment algorithm tend to do so well. So that patient that the presenter was discussing about yesterday, that came to accuse them that they lied to her, I can bet you that if we review that patient, they did not choose the right treatment algorithm for that patient. So I'm trying to explain why staging and grading is very important for pharmacists, because it will help you to counsel your patients properly. It will help you to know the right treatment goal for your patient. So I think we've done well in recapping what we did yesterday. Our today's presenters, are they here? Let me make them co-hosts so that they can start sharing. Hello, Famtikare, are you here?
Yes, ma'am, here.
Please, okay, just speak so I can see you to make you. I'm looking for you. Can you just, I've seen you. I'm making you co-host. Please start sharing your slide while I do the introduction. Where is your co-presenter? Sani, are you here?
Yes, I'm here.
Okay. I'm making you
070.
co-host.
070. Yeah.
Oh, 070. Wait, I made the
Yes.
wrong person. Famtike, please start sharing your slides, please.
I've started sharing already. Please let me know if you can see my slides.
Yes, we
That's it.
can.
Yes, they are clear. They are there.
Thank you.
Please just give me a minute. Please, a minute. I'm trying to get her citation. Sorry. Please, can you hear me?
Yes, we
Hello.
can. Yes, yes.
From TK, your citation you sent to me is not opening. No, I don't know why. Oh, even on my phone, it refused to open.
Okay, I think I can introduce myself.
Please go ahead. Thank you. Thank you. Go ahead, please.
Give me 1 minute. So can everybody hear me?
Yes, we can hear you well.
Okay, good morning, everybody.
Joining us
Good
from US.
morning.
Thank you.
Thank you very much for this opportunity to speak to you once more. My name is Olubukola Tikare. Everyone calls me Buki. A pharmacist. First of all, like that's like my passion, my greatest, I would say my greatest achievement in life is going to pharmacy school. I went to school in Olabisi Onabanjo University. In 2008, I got my Bachelor of Pharmacy degree. And in 2011, I got my master's in clinical pharmacy, international practice and policy from the School of Pharmacy, University of London. And then from 2013 till 2024, I've been working as a clinical pharmacist at the Federal Medical Center in Abuja. I was inducted into the college, the West African Postgraduate College of Pharmacists in 2021. And what else? I'm currently a consultant clinical pharmacist, also at FMC Abuja, and I was appointed to that position in 2025. But currently, I'm undergoing research training, doing a PhD in clinical pharmacy, translational sciences at the University of Michigan in the US. So please forgive me if my voice sounds funny. It's like 4 a.m. at my location. So please forgive me. I hope you can all still hear me.
Yes, we can
Loud
hear
and
you
clear. Go
well.
ahead.
Yes.
Yes, we
Perfect.
can.
Thank you. Thank you so much. My research really is on improving medication for breast cancer survivors after they're done with active treatments. And this topic today is like what I try to do with my research, improving and optimizing the role pharmacists play in the management of breast cancer patients. So that's like a little summary of who I am and what I'm currently doing. Well, I'm still in the employ of FMC Abuja, so I'm still an oncology pharmacist. I'm still a clinical pharmacist. I'm just, doing some research for now. So I'll move on. What I really hope we would be able to take away from this session today is to be able to describe the current and evolving roles of oncology pharmacists in the cancer care team. At the end of today's presentation, I hope we'll be able to understand how pharmacists support safe treatment and help patients manage their medication, and also to identify ways to expand our roles in improving medication use and patient outcomes for patients that have all sorts of cancers. So let's move on. I'll try to be as practical as I can. Not everything I say will be on the slides, but if you want any updates to it, I can actually update before I share the slides to the committee. So let's move on. First of all, we're looking at how the oncology pharmacist functions within the cancer multidisciplinary team. So from my experience and my practice, I joined the oncology team at the Federal Medical Center in 2021. And that was the beginning of the cancer clinic or the oncology clinic at my center. So I had like a great, let's say, a great opportunity or a great challenge to kind of start how oncology pharmacy practice will be at our facility. Of course, I got support from the oncologist, from our MD, and from my HOD, and of course from my colleagues. But for knowledge purposes, let's go through the people that are on the cancer MDT, because I know we are of different facilities, different stages in our oncology pharmacy practice and careers. And I'm really hoping we have people here this morning that are probably going to be starting oncology pharmacy practice at their hospitals, that are going to be making the case for how we should practice in a way that advances not just care for the patients, but of course, the advancement of oncology pharmacy practice. So let's start by looking at who are the members of the MDT, because imagine you're the HOD at your pharmacy, for instance, and the MD approaches you like, okay, we want to set up an oncology clinic or an oncology department at our hospital. Who are supposed to be the members of this committee? So first, we typically will have the pathologist, because most oftentimes they are the ones that will get the samples, after the biopsy has been taken, they will be the ones to run the tests and then give us results. So they are typically also part of the MDT. A second is a surgical oncologist. I heard Fahmi Jama talking about regimens and surgeries. So sometimes it's the surgeon. Some of the surgeons have, I don't know if they have a subspecialty or some kind of extra knowledge in surgical oncology. So typically, like in my facility, they are typically part of the MDT. Also, the radiologist, because all the time you need some CT, MRI, all sorts of tests to properly stage to even know what's going on with the patient. Another member of the committee or the team is the oncology nurse. We really can't do without the oncology nurses. And sometimes we work in partnership, or we collaborate to offer best care for the patients. And of course, the radiation and clinical oncologists, they are typically the ones that drive a lot of times the MDT, and that has been my experience at my facility. Of course, sometimes Fahmi Jama, I heard her talk about really understanding what is the goal of therapy for the patient. Is it palliative? Is it curative? Sometimes it's just palliative, and in that instance, you need the palliative care team to help or to guide the patient really on what to do. Another member will be the navigator, because if you agree with me, if you sometimes I think we take some things for granted as pharmacists, like, oh, we know the hospital. If our family member is unwell, we know where the lab is, we know where the doctors are, we can call. For patients that come to the hospital, sometimes it's difficult to even find their way around. Like, what do they know? Like, because they will expect you to go and collect your results in pathology, take it to the lab, take it for x-ray, it is a lot for a lot of patients. And sometimes that's even where the wahala really starts for a lot of patients. So the navigators typically are also part of the MDT. Sometimes this role is filled by people that are trained in like sociology, like social workers, because they're able to serve various purposes within the MDT. Another member will be the psychologist, because we all know how disturbing a cancer diagnosis can be. Imagine you have a lump in your breast, or a family member does, and you go to the hospital thinking, oh, it's nothing. Half of the time you're wishing that it's nothing. But you get to the hospital, they do all these tests, the pathologist does their work, the radiation oncologist and the radiologist, they come to a diagnosis. Sometimes it's a difficult time for patients. If you're in hospital, you're in clinic and you're seeing patients, that very first encounter is usually a full bucket load of emotions. So typically, most patients will be referred to the psychologist just to help them manage everything that is going on, because cancer treatment is typically a journey, whatever the goal or the intent of treatment is. So on our team in our facility, we have a psychologist included in the cancer NDT, and also the dietitian, because we know diet plays a whole big role. And sometimes, I don't know how many of us have seen cancer patients, you will hear all, you will hear all sorts of, you hear all sorts of things like, oh, they say I should eat this, they say I should not eat that. And sometimes some of those things even kill the patients faster than even the cancer, because there's a lot of mistruths, a lot of all sorts on the internet, all sorts people will tell you to do and not to do. But that's not really the focus of our presentation today. So I'll continue. So I'll ask a question so it's as interactive as possible, and I'm sure that you people can hear me. So who do we think is missing from this team?
The pharmacist.
Pharmacist.
Exactly.
Oh,
The
the
pharmacist.
Exactly.
The
So
major one.
thank you. So almost every treatment of cancer involves medication. And of course, pharmacists are the experts on medicines, in accessibility of it, affordability of it. In fact, everything to do with medication. They drum it into our ears that we are the experts on medicines. So you notice that I am not talking about pharmacist, just pharmacist. I'm talking about the oncology pharmacist. And to be an oncology pharmacist, you have to be trained. So that's why I'm so happy that I can see over 80 people here getting trained in oncology pharmacy and, trying to improve their knowledge in oncology pharmacy practice. So there's another person that is missing from this team. I don't know who can help me or who can think about who else might be missing from this list.
Okay, welfare.
Social worker.
The
Okay.
medical director, medical doctor.
The lab scientist.
Okay.
Radio pharmacist.
Okay.
The
Medical
patient.
oncologist.
Welfare team. Welfare team.
The
Welfare
patient
team.
or
Exactly.
caregivers.
Thank you. So that's, yes, the social welfare people, like this list is not exhaustive, but there is a very key member of the committee, which is the patient and the caregiver. For two reasons. All what we do is for the patient. So as much as possible, you want the patient to be involved in decision making, in every step of the way. You want to make sure you're capturing the patient and you're respecting their wishes, because that's something sometimes that we don't do very well in our society. I had the privilege of listening to some cancer survivors yesterday, and they were talking about how, yes, they were in clinic, they had all of these people on the MDT speak to them, but because of the diagnosis and everything that was going on, they could hear what all of us were saying, including the pharmacist. But by the time they got home, it was a lot for them. So typically, you encourage people to come with, a caregiver. It could be their some family or friend. So just even soak up all of that information and help them navigate, all what is happening. And in our country, for instance, a lot happens with cancer patients. I think we'll talk about that during the course of this presentation. So it's important for us to know that the patients and their families or any designated caregiver is also a part of the cancer multidisciplinary team. So let's move on. Thank you very much for your contributions. So I'll move on to the next. So really, the question is, what are the roles of oncology pharmacists in cancer care? You notice that I'm emphasizing the oncology pharmacist. So there's an expectation for training. Luckily, the West African Postgraduate College of Pharmacists now have like specialization for oncology pharmacists, which is something that we should all take advantage of and also attend seminars and webinars like this. So basically, oncology pharmacists play a critical role, like we have said and we have all agreed, in improving cancer treatment outcomes. And their work spans clinical care, patient support, system level impacts where you're part of decision making in your hospital, just based on the fact that you're an oncology pharmacist and your role is essential in multidisciplinary cancer care team. So before I move on, I just want to ask one question. Is there any pharmacist here that is practicing in a cancer center where they do not have a cancer MDT or where the pharmacist is not part of the cancer MDT? Okay, it means we are all part of some MDT. Is that what that means?
No.
Wow. Okay, so I think I have some slides that address that at the end of this presentation. So we'll talk about it because it's an expectation. Okay, Dr. Williams.
Yeah, I don't belong to an MDT.
Okay. The next question will be, do you have an MDT at your facility?
Hello. So I think the question is for those who are practicing.
Yes,
Who are
those are.
actually practicing in
Some of
hospitals.
us
Yes.
are in the classroom.
Dr. Williams is an academic. I don't think you have.
Me too. I'm an academic.
Hello.
Yeah. So I think the question is for those who are actually practicing.
Hello, Prof. Why
Yes.
I used to
academic? Why
I
Sorry.
used
Sorry.
to
Come again.
be
academics? Hello,
I used to
hello.
be a
Let
member
me
of
speak.
MDT.
Hello,
Yes,
hello.
ma'am, we can hear you.
We
While I
can
was
hear
in the
you.
hospital, practice, I'm even a vital member of a multidisciplinary team, MDT.
Okay,
In fact, I wrote
perfect.
the proposal for the setting up of that MDT in our hospital.
Okay, great. Thank you very much for
Yeah.
sharing.
For
I think at
Dr.
the
Williams,
yes,
while I'm
ma'am.
not in the hospital, we have affiliation with UITH, and UITH has an MDT. But I'm looking
Okay,
at a situation where even the academician, with the interaction rounds with the patient, will be allowed to be part of the MDT. Thank you.
Exactly.
okay, thank you very much. For me as a person, I believe anything is possible, but I also believe that nobody is going to hand us anything on a platter. So we have to advocate for ourselves as pharmacists. So I think I have a slide or two about this at the end. So probably we can discuss more towards the end of the presentation on some challenges that we face. So let's move on. Thank you for your contributions. Sorry, I don't know why my slides are not moving anymore. Okay, perfect. So what are our roles within the MDT? I know a lot of us might be familiar with this already, but once more, I would remind us just so that there's somehow we are not, there are some areas we can improve upon, and for pharmacists here that might have the opportunity to start up their own oncology pharmacy practice and joining the MDT, because there are some cancer centers where they have the MDT, but the pharmacists are not, participating as much, or are not even like a part of that MDT, which is really important. So I've grouped our roles into like 5 domains, which are clinical care, education safety, patient support and advocacy, collaborations within the team, and something that is very, very important, and it's so dear to my heart, is quality improvement and research. And I think that's something Dr. Williams was talking about. And this is areas we can collaborate as clinical pharmacists with our colleagues that are in academics. We'll talk about this during the course of this presentation. So let's go into those domains one by one and try to understand what our roles are, just in case we are not doing as much as we should be doing. So look at our roles in clinical care. So pharmacists typically will contribute to treatment decisions. So like in my practice, I'm typically in the clinic with the consultant. So like every decision, every medication, like, oh, if they're prescribing, they're running all the body surface areas and, doing everything for the patient, I'm there. Like our team is there, not me alone. Any of my colleagues is there as a pharmacist within the team. And trust me, like the oncologist will be asking you questions. So like if you don't know something, you have to like quickly either check, Google it, or, know that by the time you're coming for the next clinic, you have known all your, cyclophosphamide, doxorubicin, at least the commonest medication, because we know the common cancers we see in our country and in our climate. It's like important for us to at least have a working knowledge of the typical medications, the adverse effects of those medications, because you don't want to be checking every minute. And another thing is, by the time you spend some time in the clinic and within the MDT, those things just come natural to you. Also, we're supposed to help ensure that therapy is appropriate for each patient. I think I heard from IJ talk about this earlier, about a patient that was probably not getting the right staging. If they're not getting the right staging, they're not, if there's something missing on that link, it's of course going to affect the regimen that you choose. So the onus is on you as a pharmacist to be as involved as possible, so that you're part of, the team that makes the right decision for the patient. And our role is central, really important in improving the care outcomes and the health outcomes of patients that have cancer in our facilities. Also, like what we used to do a lot in our facility is to review treatment regimens for appropriateness. And you can't do any of this if you don't like at least know like some basics. I heard from IJ talk about it, I think in the recap, about the NCCN guidelines, and there are quite a few of those guidelines that we use in our facility, and we just try to be, conversant with like the basics of it, so that when you see a prescription, you know what to do. Factors like age, like patients that might have some form of, impairment, either hepatic or renal, based on age. Sometimes you also have to look at all of that when you see prescriptions. And of course, like there are cases where you have older patients. The fact that you have cancer doesn't mean that you don't have diabetes or, hypertension, which you're already taking medications for. And sometimes, because of the way, practice can be sometimes, the oncologist might be so focused on the, managing the cancer that they almost would, in quotes, forget about those other comorbidities that might be going on, So the onus and the responsibility sometimes is on the pharmacist to learn and to know their patient, like, okay, this patient is having this medication that might interact with this other medication. So that's a critical role that we play within the MDT. And our input is really important in helping the team make the appropriate decision for the patient. This is a very critical role that we play. I think we do that across all, whether you're practicing in the outpatient or inpatient or whichever, specialty you are. But it is especially critical for oncology pharmacists who are handling chemotherapy drugs, because we know that these drugs are extremely hazardous. If you go a little over, like if you're taking paracetamol, for instance, and maybe you take 2.5 in quotes instead of 2, once, it might not kill you. You might get away with it. But with chemotherapy drugs, it is a totally different ball game. You want to be sure the patient is weighed each time they come for clinic. You want to be sure that they are properly calculating the body surface area, which is what we use to, in some cases, write and calculate doses. And you want to be sure that all their organs are functioning properly. In my practice, like before you administer chemotherapy, you have to ensure that all the labs are, within range. And if they're not, you send the patient home till, with management, of course, till they are okay to receive chemotherapy. And you want to, as much as possible, at least have an idea of what are the ranges. Most of the time these days, they will even tell you like what's the reference range or is outside of range. So those are things that we, should take very, very important note of when we're in clinic and when we're seeing patients. So you want to be as sure as possible to verify the doses. A lot of times, there's no much in terms of pharmacists getting sued. But these days you will hear people go on social media and say, oh, the pharmacist did something, the pharmacist did that, and before you know what's happening, it's going viral. So I think it's really important for us to, take this dose verification of chemotherapy medications before they're administered very, very seriously, because small errors can lead to serious toxicity for the patients and also even reduce treatment effectiveness if we're not getting it right. So most oftentimes you want to have that dosage calculated each time the patient is receiving chemotherapy, especially if they're receiving like the cyclophosphamide, doxorubicin, like the IV medications that are typically dosed based on body surface area. That is really, really important. And there are a lot of resources online. Typically, like in my practice, the nurses will weigh the patient and take the height, and then the oncologist typically will calculate the BSA and use that information to what's it called, to prescribe. But it's also important for us before we dispense or before we reconstitute to make sure that those values are accurate each time the patient comes, because a lot of weight variations happen for cancer patients taking medications for so many different reasons. So we move on. Another role we play is to monitor patients for treatment response and side effects, especially side effects. And that's one area where we can really contribute and make impact, not just within the team, but for the patients, to be able to tell them of side effects. Because if you're a cancer patient, for instance, and you share that information with maybe a friend or a coworker, before you know what's happening, everybody has told you all the different, all the different things that can happen. Like, in fact, most of the people giving you information are not in any way even medically trained. They'll tell you, like, I had a patient in my facility that, in fact, she had all the staging, had all the pathology, basically had everything up to the level of, getting a prescription. And she refused chemotherapy. Like, the husband was like crying because she was early stage breast cancer. A lot could be done for her. And she said, no, she heard that the side effects of chemotherapy used to kill people. She will lose all her hair, this and that will happen. In fact, that she's not taking those, in her words, poisonous drugs, that she was going to go and take herbs. And then I think it was when I think there was a particular supplement that was really, raining on people's lips at that time. And that's what she decided to take instead of chemotherapy. And of course, we know what would happen. She'll be fine for a while, but unfortunately, um, the outcome wasn't the best. She could have lived so much longer because they caught the cancer early. So these are, areas we could also, be very helpful and supportive for our patients. And we're able to, based on our training, we're able to identify all of these issues early, especially when we talk to patients. You'll be surprised things that patients tell you that they do not even tell, the doctors. Like, there was a patient we had, of course, she was taking her, chemotherapy. She had about 8 cycles to take, and she would come with her tongue. Her tongue was, always black, and the oncologists were, really worried, like, oh, they were checking, oh, pharmacist, what's this? Which side effects is this? Like, oh, this, that. I was wondering, like, I've not seen something like this before. So they were like, okay, they will figure it out. Maybe before the next chemotherapy regimen, they'll try to figure out why her tongue is black. All of us were worried, like, okay, which side effect is this? What do we give as, supportive treatment? Do we give vitamin C? What do we do? Do we send her off to the dentist? Everybody was worried about that. And then she came to the pharmacy and she now told me, she called me that, pharmacist, I couldn't tell the doctor, but there's one herb that somebody told me about. So I use it because of course, you know how chemotherapy sometimes can affect the appetite. So she was using that leaf to wash her tongue. So it had absolutely nothing to do with chemotherapy she was receiving. But because she was, in quotes, scared of the oncologist, scared of the doctors, she couldn't tell them exactly what was going on. And then she put me in a difficult position because she was like, oh, pharmacists, please don't tell them that I told you. So that was a really difficult thing to do because I'm supposed to keep patient confidentiality, but I have information. So how do I tell the consultants not to be worried and doing research on this, newest side effects without, betraying the trust or the confidentiality that the patient has placed in me as a pharmacist? So it was a really tricky and difficult situation at that time. But the moral of the story is that as pharmacists, we're able to speak with patients, and most oftentimes they feel free with us to tell us things. That is why our role within the MDT is critical. And if you're not part of an MDT, we have to work on that, going forward from today. And another role we can play is to, support timely adjustments of therapy based on, a number of factors that we'll discuss in the course of this presentation. So let's move forward. Another domain that I would like us to talk about is safety of medication. I don't think there's anyone else within that MDT that has this training or this role or this responsibility that we have as oncology pharmacists. We're supposed to be the custodian, we're supposed to be the experts in medication. So if anything goes wrong with the medication, in all honesty, the pharmacist should be held responsible. So let's look at our roles when it comes to medication safety as oncology pharmacists. So first, you have to ensure that you're giving the right drug to the right patient at the right dose, via the right route, and at the right time. This is something we have, talked about a lot in pharmacy school, but it's really critical for, oncology medication and chemotherapy drugs, because you want to ensure that the prescriptions have been reviewed and are dispensed, the right patients, especially in a facility where there are loads and loads of patients coming, and sometimes we might be the only oncology pharmacist, and we get maybe interns or corpers to support us. We also have to ensure that the right medication is given. And you want to, as much as possible, also identify, prescribing errors when the improper or the incorrect drugs have been selected, if there are mistakes, if the orders are incomplete. Because sometimes, like in my facility, the first time the patient comes and, they've done all the investigations and they're getting their first chemotherapy medication. So they will get their chemotherapy prescription, and then they will receive another prescription for, like, vitamin C and iron tablets. And something that I noticed is that sometimes patients will take the iron tablets, prescription, they will fill it at the pharmacy and, only take it for the period that was prescribed for. They would not remember, or the oncologist might not remember to rewrite them a new prescription each time. So when they take that first few weeks, they don't take it again. And that, causes another whole set of, issues for the patients. And in a lot of settings, the pharmacists serve as the final safety checkpoints, helping to prevent medication errors, and, especially where we have, resource limitations. And I think something that is really important here is, a lot of times we pick up prescribing or medication errors, in facilities, in the clinic. I think one area that we can improve upon is the documentation of these interventions that we have as pharmacists. And I think that's important for quality improvement, but also in advocating for our presence within the MDT, because typically a pharmacist should be in the MDT, but sometimes a lot of things go on, and for some reason, we're not included. Or if we're able to document all of these interventions we make as pharmacists, we're able to, put that data together and inform, quality improvement measures within our hospitals, or even within larger spaces, as we collaborate with each other across facilities. So let's move on. The next, which is, like, this is one area that I believe oncology pharmacists are also so critical and so important, which is chemotherapy preparation, which we typically call reconstitution. Oncology pharmacists are supposed to be responsible for the safe preparation and compounding of chemotherapy agents to ensure that it's accurate and sterile. That's why we have the, biosafety cabinets. I tried to find a picture of this, but I couldn't find one immediately without all the whole copyright issue. But pharmacists are supposed to be the ones compounding, or reconstituting chemotherapy drugs, because these drugs are really hazardous, both to healthcare workers, to even the cleaners that are, taking them out. And it's supposed to be handled, not just the way they handle medications in outpatients or other pharmacies within the hospital. So it's really critical that this role is performed by pharmacists. And this is an area we can advocate, even if we're not doing that already in our facilities, due to, resources or space, but it is like a lot of cancer centers, I hope in the future would only be set up when you're sure that you have like a reconstitution room that is manned by an oncology pharmacist. And I think part of this workshop is like a physical in-person opportunity for us to get trained in reconstitution. And I really hope and I encourage all of us here to take advantage of that opportunity. I had that opportunity in Lagos in 2021 at I think it was NSI Luth, to see how chemotherapy reconstitution is done. And I think that's one area where as pharmacists we can really support and help our patients to achieve the best clinical outcomes they can. This is 2026. We don't want chemotherapy medications being reconstituted at the bedside. That's like wrong. So sometimes they'll say, oh, there's resource issues, but I think we can advocate for having a constitution room in every facility um where we have chemotherapy or where we see cancer patients. So let's move on. Another area is managing drug interactions. I think this is another area where pharmacists can do a lot, because that time you have with I can't even begin to tell you the things that I've heard patients tell me that they're taking, in when they're at home, that they don't tell the doctors. Like they are taking all sorts of herbs in addition to chemotherapy medications that are toxic. So sometimes when you hear side effects, you don't even know, like, you don't know where it's coming from. Is it the chemotherapy? Is it all the, all the only God knows what supplements that they are taking? Is it the herbs? And we are Africans and we know how we all did pharmacognosy. So sometimes when people are saying, oh, don't take herbs, for me as a pharmacist is like, I don't even know where I belong. But what I often tell patients is just let's do the chemotherapy first so that we know what's working and what's not working. I know all of us would have different or differing opinions on this, but I think we can discuss this probably at the end of the presentation, because if we are true to ourselves, patients will do what they want to do in their house and they will not tell you, or they might tell you as a pharmacist because they expect that you will not be judgmental. But sometimes patients are taking a whole lot more. And when you have treatment failure or exacerbated side effects, sometimes you don't know if this is what is even causing it, or maybe that's even what is helping them. So it's a bit difficult to know which lane to follow when it comes to drug interactions. But typically what I do when patient asks me is like, I say, okay, just let's hold off, on all of the, except of course if it is, things that we already know, have no interaction and help in some form of way. I think there are some herbs that help with blood. Well, you have to be very, very, kind of very careful, and as much as possible, if possible, document all of those interventions so that if anything happens, they won't say, oh, but I told the pharmacist and the pharmacist did not say anything. So I felt it was okay to take all my, bubu niche that I take at home. So this is important for us to also take a note of. And of course, there are other interactions, not just herbs. There are other medications patients are, taking that might need dosage adjustments or substitutions based off on, having them take chemotherapy. So these are some important things that we should at least have at the back. We might not know all the whole panel of, interactions, but I think it's, guides our thinking, because when you're like, for me, when I see a cancer patient, there's a lot going on in my head at that, point in time. Okay, so let's move on. Another area we can support is in helping manage toxicities of these medications by ensuring that they get all the, supportive care medications that they need per time. And then we are able to quickly identify and, manage these toxicities in collaboration with members of the MDT and, the oncologist and all of the other people that are involved. So we move on to, patient support. I think this is one area where we can, really support our patients as pharmacists, which of course is in counseling. We need to know our medicines. We need to know the side effects so that when we're talking to them, from a place of knowledge. These days, there are a lot of medications that are even oral. We need to be able to at least know the side effects, know, like, how do we even, counsel our patients on how to take these medications when they're at home, to ensure that the information they're going away with is the right information, because there's a lot of information out there, like I said earlier, and not all of them is, entirely true. So patient counseling is one of the roles that that's like a typical role a pharmacist plays. But as an oncology pharmacist, you need to, have like an extra layer of knowledge so that you're giving patients the right information. Next is like adherence. So typically, a lot of factors could affect adherence, for a cancer patient living in Nigeria or living in Africa. A lot, can go on. But as oncology pharmacists, we are able to help ensure that, patients can take their medications as is prescribed, especially when, we have a lot of medications these days that are oral, so we might be able to help, support them in that role. But I know a lot of times there is a problem of cost. And I think we'll talk about that later. And of course, side effects, which is something that, almost everything we do has some form of side effects. But for cancer patients, it can be a whole lot more. And it's important for us to kind of tell them that without, scaring them, because sometimes patients, just like I said, the patient we had, because of all of the things she has heard about, chemotherapy medication side effects, she refused treatment for an early stage breast cancer, which for me was, really heartbreaking because the outcomes were really, really, really bad for her. So it's important that we're able to offer some form of, support in ensuring medication adherence. This is an area, I think this is one of the greatest challenges patients face when it comes to, managing cancer care, which is, financial toxicity. Like, even they had to coin to show how important it is, not just in Nigeria, but across the world. Like, this is a field that some people do research in. And, for instance, you have HER2 positive breast cancer, you have to take, cyclophosphamide, doxorubicin, which are maybe not so expensive. But now they tell you have to take, trastuzumab and, pertuzumab, which is in the millions. And imagine let's say you work as, let me see, which role can I even think of now that is like the highest paid role in Nigeria? Okay, maybe not a politician, but let's say you're a pharmacist, for instance, and you're treating breast cancer, and you have to take maybe 17 to 18 cycles of a medication that will cost you upwards of 1 million naira. And you have to take this, for your treatment. You can just imagine how much that costs for a typical Nigerian, or even, even if you live, in another country and you don't have insurance, this is a lot. And I think that's one of the greatest barriers that I have seen for patients that, sometimes they just abandon treatment because they're like, okay, let me let me just go and invest this money for my children, or, I don't even have, that money. How do I support, my treatments? So, we are the custodians of the medication. We know the costs. And when we are reviewing treatment plans or making decisions with the oncologist, I think this is a way we can actually contribute, by helping patients. Sometimes there are patient assistance programs, there are sometimes donors, and sometimes pharmaceutical companies also support, form of, like rebates or discounts for patients, which sometimes can actually um, make a difference. So the responsibility lies with us to try and identify cost-effective options to ensure that, treatment is not interrupted for patients by financial challenges. In my practice, I had a patient, I think this was like 4 or 5 years ago. Then there was no, you know, that fixed dose combination of trastuzumab and pertuzumab. Then it was just trastuzumab, and I think then it was still relatively, cheaper. So she was supposed to take about 18 cycles of trastuzumab, and she was on cyclodoxil, and then she was going to take for 4 cycles, and then take paclitaxels for for the second 4 cycles. And she had about 1 million naira that somebody gifted her, to support her treatment. And then I think trastuzumab was about 400,000. So she was able to get, of course, she was able to get all of her chemotherapy, and she was already metastatic, so there was no need for her to even have any surgery. But she got 3 doses of trastuzumab, and that's where it stopped. She couldn't go further. And that was difficult. That was heartbreaking. But nowadays I think there are, other supports, programs. I think the federal government has some package. I know it's not a lot, but these are resources that sometimes cancer patients are not aware of. But as pharmacists, we're able to have that information and have that knowledge, and also for our patients. Addressing a lot of these costs can support adherence and improve, treatment outcomes for patients. So important for us to advocate, for our patients as they make care decisions, so that treatment plans are realistic and achievable. There's, no use writing a prescription for a patient when you know that they cannot, in any way, afford it, without having that conversation like, okay, what are the options we have within, this within this space. What we used to do in my practice is like we have a financial, oh, I can't remember what we used to call it. Like it's almost like a financial consultation where we have the prescription, we sit down with the patients, we do the maths, like, okay, this is what it is going to cost. You know how they say if you want to build a house, you sit down and cost it, so that we know that, okay, this is how much, if I'm going to go and look for support, this is how much, we this is how much I'm looking for. And what we used to do a lot of times is that we even used to, help, not like the pharmacist, but within the team, we will write a letter of support for the patient if they can, seek support from maybe charitable NGOs and, family, just to kind of, offer as much support as we can for patients, because cancer treatment is extremely expensive. So I'll move on. Another important thing is to collaborate within the team. This is so, so, so important. All of what we do is, there's something that Professor Wanang used to say, and I never forget it. Like how pharmacists always want to practice in silos. In oncology pharmacy practice, like oncology care, you can't even, like, it's not possible to do this. It is, almost, it is like a no-no, because the more you collaborate, the better, the better the outcome for the patient. Oh, okay, sorry, I'm just looking at the chart to see if there's any information there for me. Okay, so we move on. Can everyone still hear me?
Yes, we can hear you. Yes.
Yes, we
Okay.
can hear you.
Thank you. I thought I was talking to myself. I've not heard any voices for a while. Thank you very much. So, our role is to collaborate within that team, and we're part of the team caring for the patients. So we're not just the people dispensing medications. And I hope that there is nobody on this call that still does window dispensing, because I think we have abolished that in pharmacy practice. So please, if you're still doing window dispensing in your facility, please just hide your face. Don't even say anything. But please, it's important for us to upgrade our practice. Our role really, as much as possible, ensure that every treatment decision that is made, you are part of it. And this means that we cannot just sit down in our offices as oncology pharmacy practice, pharmacists. We have to be proactive about, being on the team, making our impact felt on the team. Because typically when an MDT is set up, there's already the people that are supposed to be there. But the more relevant, the more inputs you're able to make as a pharmacist, the more respect the other team members, have for you. I think the next person that is going to talk would shed a whole, light on that, because she did that for her research, and it would be interesting to see what other healthcare providers, said about the pharmacist, and that will be after this presentation. So I'll move a bit faster, just so that I can give my other team members, time to talk. So, like I said, we work with doctors, nurses. So teamwork, team effort is really what is going to help our patients. All what we're doing is centered on the patients, not really, for any particular person within the team. And I think another important thing for me to mention here is that we are all equal members of the team. We all bring different perspectives and different into the team, into the cancer MDT. So it's important for us to know that and communicate that clearly with other members of the committee. And the last domain that I would like to discuss is quality improvement and research. And this area is, dear to my heart. I'm committing the next, 4 years to improving our research capacity. And I really believe that this is one area where pharmacists can do a whole lot more with all of the data that we're sitting on. We see patients every day. We know the system. This is where, from Dr. Williams was talking about, the practice in academia. This is where we can tap into the knowledge, that academic pharmacists have when it comes to things like study design and statistical analysis, to actually, even sometimes you might not even need to start a new trial in quotes. You have all the documentation of medication errors. You have, cost of medication. You have trend over time. That makes there's a whole lot that we can do, as we practice as pharmacists and as we evolve, because really we're the ones that are going to define what oncology pharmacy practice in Nigeria is going to be. Nobody is going to come from anywhere and do it for us. It's we that have to do it by ourselves. So this is, I could talk about this for hours. So I'll just move on. So really can improve care through data. We can track all the interventions we've made. We can, all the patient counseling efforts we have done. This is rich data. And with that information, we can identify gaps that exist and find a way of improving them. I think most of the time, management, our MDs are most of the time, not all of the time, but as much as possible, it's important for us to be able to put all of this together, even present it to within the MDT at our meetings, present to management. Those are areas where we can ask. We can ask for more. We can ask, oh, we need more pharmacists within our team. We need to train more pharmacists. Oh, we are still doing bedside reconstitution. We need a biosafety cabinet. We can advocate, for things that we need within our practice. So please, let's, be more involved in quality improvement and conducting research and, take advantage of our colleagues that we have that are in academia. Another, I've talked about this already. We can improve our practice, improve care delivery, but we can't do all of this if we do not have data, we do not have studies, if we have, like they say, no, what is not documented is not done. So this is really, also important. And I think a lot of times pharmacists can also be part of clinical trial study teams. And people outside the country I don't want to use the word encouraged, but they're able to, know that, okay, the pharmacist has the capacity to deliver on, skills that a typical, like other pharmacists that are not trained in oncology can, not offer. So this is really important. And I think going forward as pharmacists into the future, because a whole lot is changing with quality improvement studies and research, we'll be able to, contribute more and take our practice and our knowledge further. So I think this is the slide I was talking about when I asked how many of us have, cancer MDTs or are part of MDTs within our facilities. The truth of the matter is, yes, we know our roles, and sometimes I would not be ignorant of the fact that practice environments differ and we all, face different, challenges. Sometimes you're not even within the MDT or there are factors like I call intrapersonal, even we sometimes as pharmacists, we're not as proactive as we should be. Or sometimes when we are, like other healthcare providers might not, in quotes, appreciate our contributions. But as much as possible, I think from my experience within oncology care, I think the pharmacists are highly respected and deeply regarded just because of the recommendations and the inputs we can make. So I just put this slide up here as, some challenges we can face, especially when we are starting for the first time in maybe an environment that is not so friendly. And I think that's where OPAN and the resources, the oncology pharmacy network we have in Nigeria can be so, important for us to learn from. Like when we were starting up, in FMC Abuja, it was even the oncologist in our facility that introduced me to, oh, there's an oncology, she knows there's an oncology pharmacy, association, she introduced me to, the pharmacist Ramatu and pharmacist Bulus that are in ABUTH. Through there, I met IJ, I met the pharmacist in Benin. I could, reach out to them if I had questions because I was starting for the first time. Like I had then the WAPCP didn't have that oncology specialty then. So I was learning on the job, calling, people. And I think that's something that is really a rich asset that we have within oncology pharmacy practice in Nigeria. So almost any challenge that you can think of is already something someone elsewhere has already solved. So you can just basically call and ask. Sometimes we have, prescriptions issues, you don't have enough pharmacists. And sometimes even within the pharmacy, like they might say, oh, you might find some HODs that don't even see how important it is for you to specialize in oncology pharmacy care. Like you can get all the training, and before you know what's happening, they've posted you to, adult GOPD. But these are real life issues that happen, but there are issues that we can also that are not totally unsurmountable. There are things we can, take care of. So that's why I, put this slide up. I'll just if I have how much time do I have left?
Please continue. Continue.
Okay, I just want us to maybe take a few minutes. I don't know if we should just put it in the chat, or if someone wants to say, okay, we're all here from IJ is here. I can see a lot of experienced pharmacists here. We could just, because this is a workshop, really. This is adult learning. A lot of what I said we know. But I think that, the challenges we faced are areas we can actually maybe take a few minutes to discuss, and maybe people in the audience, or maybe not me, maybe from ID, maybe someone else might be able to have profile solution based on their experience. So this is for our participants. If you're within the MDT, or you're yet to start the MDT at your facility, and you can think of, or you already face some challenge, and you want to share, maybe we can suggest some solutions you could think about. So I don't know if we can take maybe 10 minutes or less, if I don't know how much time I have, to, you can shout it, you can unmute and say, or you can put it in the chat, just so that we can actually go back to our facilities and, start to think about what we can do, so that next time we're not just, going back and forth. This is a workshop. So there are expectations that for the 80 or so pharmacists we have here, we have 80 new biosafety cabinets in oncology pharmacy, spaces in 80 cancer centers in, across West Africa. Samson, yes, please go ahead. Mr.
Hello,
Samson.
Dr. Ezia, go ahead. Dr. Ezia, your hand is up. You can go ahead and speak.
Okay, thank you so much for this lecture. It's been a very wonderful one. Personally, I'm in the academics and also in pharmacognosy, a natural product. I was so happy for what you were sharing on drug interactions, looking at Africa generally and Nigeria in particular. You can't separate, to be difficult. Let me not say you cannot separate, but it's always difficult to separate a patient from the use of natural products, herbals, medicaments, and all whatnot. What I've been really advocating all this while is the need to get into a research, and that's exactly what I'm doing right now with all my project students. We are trying to lay hand on all sorts of herbal products that cancer patients are using, ranging from colorectal cancer, breast cancer, prostate cancer, in several localities. I just finished a walk in Enugu State, Anambra State, Abia State, Imo State, and Ebonyi State with a set of my project students, and we are really finding out a lot of herbals that they are using, and I think we need to really find out what works and what doesn't work, and what should be the effect of these interactions with conventional drugs. I think that's really my heartbeat. It's not enough condemning and scolding them. You discover too that many of them have so much interest, and they even believe in that more than conventional drugs. So what I'm asking is, how do we get into this big challenge? Because how do we get into this big challenge, seeing that drug interaction is a matter in clinical practice, and also not justicing what really would work in terms of supplements, herbal supplements. That's really the dilemma I need to said. It would be good if we can talk about that. Thank you. Thank you so much.
Thank you, sir, for that, for your question, and thank you for all the work that you do. I think, you know, what you said is so important because sometimes the information that we give, when we counsel patients is based on the information we have at hand. So for instance, I don't know if there are any interactions between, cyclophosphamide and I can't think of any I can't think of any herb now. Maybe I don't know which herb do people typically use. I don't know if there's any interactions between cyclophosphamide.
Soursop leaves
You said?
and soursop leaves. I think that's
Exactly.
what we call
Some
soursop
Exactly.
leaves.
hospitals, sir.
Exactly. I don't
Mm-hmm.
know if
Most
there are
people
any
use
interaction
moringa leaves.
because
Mm-hmm.
if I go onto maybe PubMed or if I even do a simple Google search, would I find, enough data to say, okay, you can, take the two together without them interacting? Because we know, like in my facility, when you are driving out at the junction of the hospital, there are people that sell, like they sell soursop, they sell a lot of different things there. And sometimes when I'm going home, I see my patients there buying soursop, like all, like this is they've left chemotherapy, they just had their chemo administration or they're already on their way home. They've stopped at the junction to buy soursop, buy, only God knows what else. But we don't have, that's where research is important because the people outside the country don't face those challenges. So they might not be so, invested in, that type of data. But this is, something that is indigenous to us. We are the ones that understand that dynamic. So as much as possible, I would really applaud you for the work that you do and hope that, you're able to publish, some of those findings in peer-reviewed journals so that when we are actually, making, those advice to patients is actually, evidence-based. Because the truth of the matter is patients will do what they want to do. They might not even tell you if they not if they because I think patients are able to kind of read you. So if they see like this pharmacist is like all this oyibo kind of things. So I will not tell her that I'm taking, all of these things at home. So I think I'll say let's, do research, let's publish our work, let's, disseminate that knowledge in what's it called, in avenues like Open is having a conference. We've called for abstracts. It would be nice not just to even have only clinical work done. It would be nice to see what, other colleagues that are working in natural products have done when it comes to drug interactions with, chemotherapy agents or, other drugs that patients in cancer care use, because we can't tell patients not to take it because they will. And I think now there is there's a push even here in the US. A lot of patients are, advocating or even like taking, I think they call it integrative oncology, but that's because they have data supporting it. So we need to have our own data, basically. Yes. So I hope I have answered your question, Dr. Izado. I think it's more
Thank
of a
you.
discussion. So,
Yeah.
Other people have inputs, they can add to the conversation. Yes, I had other hands raised, 090. I think you can unmute and share your challenges, whether real or virtual.
Good morning, everyone.
Good
Thank you
morning.
for the impact. Okay, thank you for the impactful lecture so far. My name is Pharmacist Chioma from the University of Calabar Teaching Hospital. So my challenge has been this issue of posting to units that an individual wants to practice, let's say oncology, for instance. So is there a way that this can be handled such that as one is coming into any facility, they are placed where their passion is, so that the person will start from the scratch to learn the intricacies in such a unit? So that's what I wanted to ask, because it has been a challenge to me. Thank you, ma.
Thank you very much, Pharmacist Chioma. The first thing I'll say is, Mama J, what's happening? What?
My dear, you know that in pharmacy practice, we have hierarchy. You have the head of the department that has the right to post pharmacists to different units. Like she said, in UCTH Calabar, I'm the head of the unit for oncology pharmacy, but I don't have the right to post pharmacists to my unit. So, but in her own case, when she came in, she was posted to NHIS pharmacy. But when she approached me and told me that she's interested in oncology, what I did was I started giving her information, access to training. In fact, as I speak now, because we are trying to subspecialize in my unit, so I'm trying to build the pediatric oncology pharmacy team. That's a subspecialty in oncology pharmacies, and she is leading that team. She has done online trainings in pediatric oncology pharmacy. So I've been able to discuss with my HOD, ask her, she knows I've been lobbying for her since, so that she can now be posted fully to my unit, so she can be able to head the subspecialty section, that's the pediatric oncology pharmacy section. So we are making progress, because recently they employed locum pharmacists, and I've gone again to remind them that they should please use those locum pharmacists and replace her in the unit where she is, so that they can send her to me. Because the team I have on ground, we don't have enough hands to cover that subspecialty. And the pediatrics is another ball game altogether. You need to do trainings in pediatric oncology pharmacy, and she has done some training. So when I told them that she has gone further to do trainings in pediatric oncology pharmacy, and she's ready to start that subspecialty unit, so they are very happy. So we are making progress. So I believe we will sort it out very soon. So Choma, don't give up. Thank you.
Thank you, ma.
Thank you. Thank you, Pharmacist Chioma, for I really applaud your boldness and your courage to raise that here. It is so important, because it is not just UCTH this happens. Like, it happens in other facilities, and not everybody might be able to say like their experiences. But something that I believe, would be very helpful is really, being in the college, the West African Postgraduate College of Pharmacists, getting um getting a specialization in oncology pharmacy practice. It might not, like I said, is sometimes is, you have to push, you have to lobby, sometimes we don't get all of these things on a platter of gold, but we continue to push, we continue to, go to our HODs, sometimes they are friendly, sometimes they are also going through pressure from management. So I think if we can, at least get, support from our management, or at least get approval to be in the college, get oncology pharmacy training, keep, keep building that capacity, because opportunity should meet preparation. There'll be a time that, maybe something will happen and they'll say, like for instance, now imagine your HOD comes for open conference, and let's hypothetically, let's say the NICRA DG ask him, oh, how many oncology pharmacists do you have? How many units do you have? Such things put pressure on management, and they start looking for, okay, which pharmacies can we, like when I started working in oncology pharmacy, like I didn't even have any training, but they needed somebody to go there because, that hand was needed. So I would encourage you to keep building capacity so that when the time comes, you are ready, because a lot of things are within your capacity to do. A lot of things are not within your capacity. So as much as possible, if you can do the ones that you can do, so that when the opportunity comes, you are ready. So please don't be discouraged for other, facilities that are here that might be going through similar challenges. So I have
thank
other
you. In
hands
fact,
raised.
yes, just call the next
103.
number.
Okay, 103.
Yes, 103 has been raising hands since. Please go
Okay.
ahead.
Yeah, thank you so much for that insightful presentation. I'm Dr. Ifoma Umi. In academia. I don't work. I worked as an intern 2 months in National Hospital. I was posted by night breed. Then it was just a routine. Like after that, I said no to hospital practice because we kept on doing pigeonhole work, like counting drugs. So I am happy to hear that hospital practice has advanced, and it's so good to hear. So, and also thank you for that beautiful insight. It was a wonderful presentation, Tikere. So I was thinking when you mentioned calculating BSA for dosing and making sure there is no error. So I was thinking, why are we not thinking of making practice here easier for pharmacists? I had experience with a friend that works for Walgreens. And when they say, when they're working abroad, you think they're doing a lot. No, we're even doing a lot here. From my own experience, she works for Walgreens. She works from home. So I used to sit around when she's working. So sometimes they're telling you they're checking drug-drug interaction. No, they don't check it from their head. They designed an app for checking drug-drug interaction. So I'm now thinking, why is practicing in Nigeria so complex, so difficult? So how are we sure that the BSA, those calculation is correct? Do we have to sit down, manually check these things? So why is the oncology pharmacy in Nigeria not thinking of designing an app, an automated app that you feed in the patient data and it automatically calculates the dosing using the BSA formula? And also, can't we have an app, even though you already know possible drug interaction, can't we have an app that we can open and it will simply feed in the medications the patients are placed on apart from the herbal, and they can quickly run through the drug-drug interaction. So the world is advancing. I feel practice in Nigeria should also advance. So I don't know what you people think about that. Thank you.
Samtike, let me just comment
Okay.
before you answer. Dr.
Okay.
Ife, we are actually using, I'm happy you mentioned this. That is why this is a workshop, like Pantike said. It's not just about presentations. Let's interact and discuss. We are actually using apps. In fact, we have chemotherapy apps that calculate the doses. I'm using it in my center. And then we have drug interaction checker we use to analyze the drug interaction. Like you said, you feed in the drugs. The commonest one is your Medscape. Go to your Medscape. In fact, the interns in my center, when I'm speaking to them, I'll ask them, do you have Medscape in your phone? They will be looking at me. I will score them. You have all those 1,000 apps in your phone, and you don't have the one app that will help your practice. You don't even have Medscape. Let's not go to others. So if you have Medscape in your phone, there is drug interaction checker in Medscape. That's what I use. So you just click on the drug interaction checker and feed the drugs. All the drugs, including the chemotherapy, if the patient has comorbidities, the anti-diabetics, the antihypertensives, just feed all of them in the drug interaction checker. And then you read all the comments. It will help you to cancel your patient. It will help you to know what to do, how to plan the therapy, whether they are spacing the drugs for 2 hours or they are spacing for 6 hours, or they can take it concurrently, or you will be able to advise, or they can withhold, because sometimes when you are doing chemo, there are some drugs you withhold 24 hours before you give chemo, and then you can restart that drug 24 hours after giving chemo. We are using drug interaction checker in Nigeria.
But
Yes,
that's
we are.
nice to hear.
And
Is it a free app? Is the Medscape, is it free?
Medscape
Is
is an app, it's free, completely free. It's on the, just type Medscape on Google Play. You will see it, you download it. And then even the apps for calculating doses, for carboplatin dose that you use your AUC and serum creatinine is there. There is an app we use.
Okay, so that's for your center. So I feel your
No, it's
center
not for my
should.
side. I'm sure my other colleagues are using it in other centers. They are here. I have people from Abu Zaria, they are here. I have people from National Hospital, FMC Jabi is here, AMC is here. I'm sure they are using the app. Then for the commonest one we use
Yes,
in
we
Nigeria
are.
is
We
Onco.
are. Yes, we're using the app. We use app to verify.
I also using
Biological.
Yeah, you see,
We are
so
also
the
using it
commonest
at
happy
Medical
to hear.
Cancer Center too. We are using the app.
Awesome. I'm happy to hear.
we are using half.
the
Wow. Are you
commonest
Me, I
an
even use Let's See Drop, and I
anybody
pay
from
for it
Onco
every
UNTH?
year.
Anybody from UNTH? Like
Yes, from Nigeria.
Naut. Anybody from Naut?
There is nobody. Nayut is, we are yet to have oncology pharmacy presence in Nayut, unfortunately.
Okay. Because that's where we use for our rotation.
It has been an issue that I'm passionate about. So get one pharmacist in Nayut that we can train to set up oncology pharmacy. Maybe Dr. Ife, you will help me since you people are using that place for your posting.
The
Please
rotation.
help us so that we can get it done.
We
So
have
the
our
commonest
students here, so that's why we try to enroll most of our students, and I know many of them will end up working there as an intern. So I feel we should start this training, even using the Medscape. So I'll reach out to you, IJ. So try to see, because when I did my farm day in Uniben, like this conversion program, there was one app this person introduced to us, those pharmacists that came from US introduced to us. But later, after 1 year, we couldn't have access to it. So when you try to
Hypocrites.
wait,
Yes.
like
Is it
our
hypocrite?
started working. So now if there is an app, I
No,
feel our
Medscape is
final
free.
years should have access to that app. So I'll try and
Yes, it's free.
introduce it, maybe hold a
Hypocrite.
session. So IJ, I will also make an open appeal. We are going to invite you to talk to our final year students, at least give them hands-on this app. It's better they know how to use it before they join the hospital. So I will discuss with people from now. I will try and talk to their head. At least I communicate with her.
Okay, ma. Thank you.
Thank you
So
so
I
much.
was trying to say that for every oncology pharmacist in Nigeria, everyone that wants to practice oncology pharmacy, please, apart from downloading Medscape, download Onco Assist. From the name, you already know that is there. The app is there to assist you in all your calculations. There are plenty apps inside Onco Assist that you will use for all your calculations, all your analysis. So many things. It's so helpful. Please download it. It's free on Google Play. Onco Assist. Download it. Thank you. Famtike, over to you, please.
Thank you very much. Like I said earlier, all our problems will be solved on this floor today. So thank you, Dr. Ume, for for your inputs. And yes, I agree with you totally. Oncology pharmacy practice in Nigeria can be challenging, yes. But I can assure you we have grown, we have moved in the last, 10, 12 years. Like we are doing great things, and hospital pharmacy practice is now, it has changed. Like I said before, like if you are in a hospital that is doing window dispensing, just cover your face, cover your eyes. So we are making a lot of progress, but there's something that you said, about the apps, about interactions, tying it back to what Dr. Ezia said earlier. We have Medscape, yes, we have Onco Assist, yes, but are we able to check for interactions between chemotherapy drugs and herbal drugs that our patients might take that don't have, formulations that are in that app. I think that's something we can do in the future. And one of the things we said in this workshop is how our role will evolve into the future. So I agree with you totally. It's something we should hopefully the younger, generation can, use their tech savviness to, have something that actually is customized to our own, our own environments, our own type of drugs that are not, available on the apps that we currently have. And, let me speak like a participant now. I don't know if it's possible for us to have maybe just a one slide of all of these resources that PharmIJ, Pharmacist Ramatu has said that we can actually share with participants, something they can easily look up when they're in their facilities. And please, NAUTH, if you don't have oncology pharmacists, oncology something, is a big problem. Or probably we need to pay a courtesy visit to your MD. There's something needs to be done about that. Exactly. Someone talked about MDEX. Yes, MDEX, we can always, yes, I totally agree with you. We have to develop solutions for our own problems. But before we do that, we can use the resources that we have available. At least you can do a lot of the calculations, the BSAs, the interactions, the dosing, all these resources we have at our disposal, we can use for now. And then we continue to identify, issues that we can continue to solve within our practice. So thank you very much. And Dr. Williams, your hand is up. Please, you can go ahead. Dr. Williams, you can unmute and share.
Hello.
Hello, ma, we can hear you.
Yes, good morning, everyone. An area that is dear to my heart has to do with the conflict within among pharmacists that is standing in the wheel of progress with regards to career progression among our colleagues. Like it's rightly pointed out by one of the participants, somebody starts out doing self-development with the mind of specializing in a particular area, only to be posted out from that unit. You see the medics, they are specializing. So why not pharmacists? So it's an area we need to work on. I don't know the modality we are going to use to help those at the helm of affairs to realize that whatever they do for the profession, they are doing for themselves. When they have opportunity to ensure specialization, at the end of the day, the profession benefits, the individual benefits. It's like the principle of management that says that if you put personal interest ahead of general, both the general and the personal will suffer. But when you put the general ahead of personal, along the line, even that your personal objective, your personal goal, your personal desire will be achieved. So our efforts should be directed to those at the helms of affairs of pharmacy in hospital pharmacy to see to what they can do to ensure that specialization in pharmacy practice in the hospitals is ensured. Thank you.
Thank you so much, Dr. Williams. This issue has been, I don't know how to put it, it has been so heartbreaking and sad to see that is even pharmacists that are fighting specialization in pharmacy. Can you believe that? It's so bad that you will see some centers where someone has built his or her capacity, developed himself, and then you will see the HOD will remove that person and make sure that that person never practices that whatever he has built his capacity in. Like what happened in UCH Ibadan. I think it's time for pharmacy profession, maybe PSN or PCN, I don't know which one, to throw more light on this. at least make pharmacists to understand that we need to encourage specialization. I could not imagine that UCH Ibadan, that all of us, almost all of us, apart from the earlier people that started training with Roche in 2011, OPAN started as a result of the training we had in UCH Ibadan before they started Arita trial, where they brought medical oncologists and the team from University of Chicago that trained us. It was after the training in UCH Ibadan that they advised us that we should have a common front, that we should come together and set up, be together as oncology pharmacists. That's why we set up OPAN. That was in 2018. One of the pharmacists there was trained in University of Chicago. He was the one that did the first chemotherapy reconstruction training for us here in Nigeria, gave us the reconstruction manual he came back with from University of Chicago, trained almost, Benin was set up as a result of training he did. We in Calabar here, we were able to, start off because of the training. But can you imagine that UCH Ibadan oncology pharmacy practice is dead because of a pharmacist? Can you imagine that? It's so sad. It's actually so sad. I hope that PSN will do something about this, because how can you be fighting against specialization in pharmacy profession? It doesn't make sense. Instead of you to give the full support so that they can be able to upgrade themselves and do better. I did a presentation for Pediatric Oncology Association of Nigeria, that's the pediatric oncologists, for their annual conference. They invited me for a presentation. When I finished, a professor from UCH Ibadan told me that all these things I'm saying about oncology pharmacies, that they are not seeing it in UCH Ibadan, that he doesn't know what it is. I was surprised. That was when I started asking questions, and I discovered that they did not allow the oncology pharmacists there to practice, and it's the pharmacists. I hope we will start changing. TK, please, over to you.
Yes, I totally agree with what everyone has said. But I think we will continue. We have OPAN. Now OPAN works, in collaboration with WAPCP. WAPCP has been able to advocate for us to get, consultancy. Like I told you, I've been appointed a consultant in my facility. So I think we'll continue to advocate, and we'll continue to, like I said during my presentation, document the impact we've made. Nobody is going to hand us anything, Everybody is hustling for their, for themselves and for their profession. So I think, we too will have to advocate and continue to advocate within pharmacy, across pharmacy. I think that's where OPAN, WAPCP, PSN, like we use every tool in our box to continue to advocate. And I believe things will continue to get better. 10 years ago, they were not, we are not where we were 10 years ago. And I believe, as time goes on, we'll continue to make progress. So I'd like to encourage everyone not to give up. I will say I was lucky in my facility, and MDs change, HODs change. That's why we prepare ourselves so that when the tide comes and is in our favor, we are prepared. We do the ones we can do and then advocate for the ones that is beyond us. So thank you for the contribution. I saw pharmacist Abdullahi. Your hand is raised.
Okay. Oh, I almost forgot.
Sorry.
I had wanted to share two experiences. One about this herbal and orthodox medicine interaction, and the other one about financial toxicity. There was this patient we had with non-Hodgkin lymphoma. He was HIV positive, and he was bad when he came. But non-Hodgkin lymphoma can respond well to chemotherapy. He's CD20 positive, so he was placed on R-CHOP. After 2 cycles, he was doing so well. He himself said, yes, he has improved a lot. Then when he came for the 3rd cycle, I noticed some rashes and then that the tumor that has regressed has also increased in size again. I said, Chief, what happened? He said, nothing. I just noticed that he's not doing well again and what have you. I look. Now call one of my colleagues, a medicine reconciliation expert in our center, and we discuss. She now said that, are you sure this guy is not taking herbal medicine? So we ask, he's quite secretive because this is somebody that his family are not aware that he's HIV positive. When we were tracking him, we discovered that he's HIV positive. We asked him, because he had his twin brother, he came with his twin brother and his wife. His twin brother is not aware that he's HIV positive. Or that is what he thought. So we tried to find out from his family if he's taking any other thing. Eventually, his son told us that he used to send him to go and get some herbal medicines for him, and he has been taking it ever since the second cycle. So we counseled him and then tried to administer his third cycle, but his vitals were, so we had to wait. In fact, to cut long story short, that guy did not survive for us even to administer the third cycle. We'll try to find what herbal medication he's on, but we couldn't, because he sent one of his small sons to go and get it for him, and the son wouldn't know what exactly he is. Because they come from Katsina, so I told the son that if he goes there, let me talk to the person he's buying the herbal from, so that we can find out if we can trace whatever herbal medicine, because herbal medicine, there are herbs. So if we can get the herbs, even if it is the Hausa name, so that we can assess and possibly look at possibilities collaborating with our pharmacognosis. But we couldn't. I lost contact with that point. But the end is, this is somebody that started well, but possibly, I'm not saying that it is the herbal post, but that's the only thing we can lay our hand on. Is possibly interaction that will really cause issue to him. The second one is in 2024, I had a small girl, 17 years old, that came and was diagnosed with, I think, nasopharyngeal cancer. I think nasopharyngeal cancer. She was placed on medication. 3 cycles, she was doing so well. I was so happy for her. When they went to come back for the 4th cycle, they didn't come back. That's at when due. I called her sister. She said, oh, she's sorry that they are coming this week. They didn't come. Call again, call. Then one day the sister told me that actually it's issue of finances. I knew, because after the 3rd cycle, they asked for us to give them a letter to somebody that will help them with finances, which we did. She didn't come back. In fact, at the end of the day, there was a time that the sister told me, it's their mother. She said they don't have money, that maybe they will go for herbal, this prayer house. They want to go to the prayer house and all that things. Eventually, they stopped taking my call until late last year when they came back. By that time, when we did the workup, she has liver metastasis as well as lung metastasis. As I'm talking to you now, that patient, that girl, she's now 19. She's still in our center. We couldn't administer chemo because she couldn't stand it. And this a young girl, highly promising, and the effect of her problem is now impacting on her sister, who has to leave her school at University of Benin, she said, to come and sit with her, to take care of her. That's what we see. And we've been trying to see if we can get help from her, but we know that's one thing with head and neck cancer. We are always excluded on almost every other government help that we can get. But those are two things that really, in fact, they almost made me run away from oncology. Thank you.
Thank you for sharing that, Fam Abdurrahman. Fam TK, please round up so Fam Sani can start his part.
Yes, I think thank you very much everyone for your contributions so far. I think I just have one slide, and I think I don't even need to, talk about this too much because we're already showing up, we're already speaking up. I think as much as possible, we need to take action and match our words with action. And there's room for us to grow. Our role is evolving. There are a lot of questions that are unanswered for us as oncology pharmacy practitioners, especially practicing in our climates. So thank you very much for your contributions. I'll stop sharing now so that my colleagues can also share their slides. Thank you.
Who is going next? Is it Fam Sani or Fam Hassana?
Fam Hassana.
Fam Hassana, are you here? Fam Hassana, are you here?
Yes, Fam ID, I'm with you.
Just speak. Let me find it. Okay, so I can make you co-host.
Yes, ma. I'm with you, ma.
Okay, I've made you co-host.
Okay, ma.
So you can share your slide. So, Fam Hassana, please, you introduce yourself.
Okay, ma.
Text.
Are you able to share?
Yes, I'm about sharing, ma.
Okay.
I think while Fam Hassana is trying to share our slides, I'll just add that, just not to, talk too much, but Fam Hassana's work, I think, would also push the conversation further as to how we can, like how we are perceived by other, healthcare, providers within the cancer MDT, and how we can, I think this is a conversation that is ongoing, for as long as we practice. We'll have new challenges every day and, ways we can continue to evolve as oncology pharmacists. When I started working as a pharmacist, I don't even think there was anything like oncology pharmacy specialty, but we have that today, and I believe things, will continue to get better.
Yes, thank you. I think if you notice on the training group, I dropped a circular. That circular is the circular from the Federal Ministry of Health on MDT. So, because so many people have been asking that they are not part of the MDT in their
Hello,
center,
ma.
how?
Hello, ma.
Yes.
Sorry,
Yes.
it's showing host disabled attendees uploading their slides, something like that.
No, it's not. Do you have Zoom app? Did you download Zoom app?
Yes.
That normally happens. Then you should be able to share. Share. Fam Tikare was able to share.
I'm using the Zoom
please
already.
Fam TK, please let her send you her slide so you can share for her, please. From
I
Hassan,
think
I
I
send
might
it to from
even.
TK to share,
Sorry,
please.
it is showing post
Should be able
attendee.
to hear.
You need to log in again. That means you've been logged out.
Okay, I've updated the slide, so let me share the new one with you.
Okay.
Send her the new slide so she can share it for you. So I was talking about the circular on MDT that I posted on the forum. Please use that circular to advocate for inclusion in MDT in your center. See, the MDT, multidisciplinary team approach for cancer care, is the global standard for cancer care. And Nigeria has adopted it. I'm sure other countries have also adopted it. And the federal government is very serious with MDT in Nigeria. So if you're working in a center in Nigeria and you're not doing MDT, please print out that circular and then attach your proposal to it and send to your management. I can bet you that your management will do something about that. In my center, we don't joke with MDT, and I'm sure that most centers are now very serious with MDT. What happened in my center is that when we started pushing for it, the patients we managed with MDT, when they saw the outcome, in fact, it's even the doctors that are now inviting us for MDT, because they've seen that when they do MDT for their patients, the outcome is usually better, far better than when they were managing the patients alone. So please print out that circular and use it to advocate for MDT in your center. It will help you. Famke, do you have the slides now, please, so you can share?
I'm waiting for the slides to come to me, but just to add to what you just said, I think it's also important for us to document the impact, we have as, oncology pharmacists within the MDT, because this is what we will use to advocate for, for more things. And I agree, like, for some funding. I think that's why a lot of times we get those issues, because a lot of funding would require, the pharmacists to be on the MDT. So that's another way we can advocate for more, pharmacists to even be employed, more oncology pharmacists to be trained. I've gotten the slides. I just need to move it to my computer. Just give me a few minutes.
The challenge with MDT is that some of us are afraid of, participating in it. What if they ask you a question and you don't know, you are totally blank, you don't know what to say? Don't be afraid, please. Remove that fear. Thank God we are here for this training. Trainings like this will help you build your confidence. Like Famtike said when she was presenting, the common cancers in your center. Do your underground check. Read and prepare yourself. Those common cancers, what is the guideline for managing them? What is the preferred regimen for metastatic disease and for locally advanced, for early disease? What is the standard of care? It will help you to prepare yourself. Then for each MDTs are usually for a particular patient at a time. So try to know about the case ahead. Then go and prepare yourself, review that case. That's what we do in my center. We usually review the case with my team. We review the case, look at the guidelines, prepare our own recommendations. This particular preferred regimen for this patient, what are the required investigations? What is the monitoring parameter for this particular regimen? What do we need to, to make sure that these patients have those things, those investigations? For instance, I'll give you, for instance, in my center right now, my team have been able to make CA15-3 confirm for breast cancer patients. Okay, we can go ahead. I just wanted to be talking while we are, instead of. So if I'm Hassan, over to you. We'll continue the discussion later.
Okay, thank you so much, Pam IJ. Thank you, Opan and WPCP, for giving me this opportunity to present my research work. I'm pharmacist Hassana Ahmadu, and I work with the FCT Hospital, Gwarimpa General Hospital to be precise. I'll be talking on the perception and satisfaction of oncology pharmacy services among care providers and workers and oncology patients. Actually, I worked on the perception and satisfaction of oncology pharmacy services among cancer patients and healthcare workers, but because of the topic that was given to my team, I had to narrow it down to the perception and satisfaction of oncology pharmacy services among healthcare providers alone, excluding the oncology patients. And my supervisor is pharmacist Abubakar Daraka. Slide, please. Next slide, please. Okay. Cancer is a major global public health concern with rising incidence and mortality rates, particularly in low and medium income countries like Nigeria. According to the World Health Organization, cancer accounted for nearly 10 million deaths worldwide in 2020, and this burden is projected to increase significantly in the coming decades. In 2020, Nigeria was reported to have over 124,000 new cases, with breast, cervical, prostate, and colorectal cancer being the most prevalent. The management of cancer typically requires a multidisciplinary team approach involving oncologists, nurses, oncology pharmacists. Pharmaceutically has actually talked immensely on the MDT. Oncology pharmacy is a specialized branch of pharmacy that has become is a specialized branch of pharmacy that has. Hello, can you hear me?
Yes, we can
Yes,
hear
we can.
you.
Go ahead.
Okay. Oncology pharmacy is a specialized branch of pharmacy practice that has become critical in the continuum of care. What oncology pharmacists are responsible for the preparation, dispensing, monitoring of chemotherapy and other cancer-related medication. They also provide pharmaceutical care, patient counseling and education, toxicity management, therapeutic drug monitoring. Their contribution has optimized therapeutic outcomes, improve medication adherence, reduce medication and enhance the overall quality and safety. All the benefits and employees and under recognized in low and medium cost of systemic healthcare challenges and inadequate integration of pharmacy professional. Slide. Please, next slide. Hello? Hello, next slide, please.
I'll move the slide.
Okay. Pharmaceutically has talked a lot on the specialized role of oncology pharmacies, which include medication selection, evaluation, therapeutic monitoring, compounding, and reconstitution of safe dispensing of highly toxic chemotherapeutic agents, patient education and counseling, side effect and toxicity management. She's really talked a lot on it, so we'll just move so to save time. Okay. My study objective was to assess how other healthcare workers perceive and are satisfied with the effectiveness and role of oncology pharmacists. This study was carried out in two major public tertiary hospitals in Abuja, that is the National Hospital Abuja and Federal Medical Center Jabi. They are known for their specialized oncology services, and they have functional oncology pharmacy units and also oncology units. Please, next slide. The sample size for this study was determined using Yamani's formula with 322 participants, 299 are patients, where 23 are healthcare workers. And the study design was a descriptive cross-sectional study using structured questionnaires which was adapted from other studies that had been carried out by other researchers. The participants for this study include physicians, nurses, radiotherapists, lab scientists, and all involved in oncology care, excluding pharmacists. From my results, you could see that 69.6% of healthcare workers recognize oncology pharmacists as part of the healthcare team, but the frequency actually of collaboration actually varies significantly. From the chart, you would see that 43.5% always collaborate with oncology pharmacists, while a combined 30.4% collaborate rarely or never. So this gap suggests that many pharmacists are in the team in name, but not yet fully integrated into the clinical workflow. Next slide, please. The good news is, for the general perception, 87% of the healthcare workers considers pharmacists essential members of the oncology team. That is, 52.2% strongly agrees, while 34.8% agreed. For the quality of care, 78.2% believed oncology pharmacists directly improve the quality of patient care, whilst for this decision making, 73.9% agree that pharmacists contribute meaningfully to treatment decision making. Please, next slide. But the challenge is, and the perception gap here is for the side effect management. Only 39% of healthcare workers felt pharmacists effectively manage chemotherapy-related complications. For safety protocols, only 60.8% agree that pharmacists enhance the safety of treatment protocols, while nearly 35% remain neutral or disagree. So there is a competency trust gap regarding clinical intervention and traditional dispensing. This I see to be lack of confidence or trust by some MDTs and pharmacists' clinical decision-making abilities, despite pharmacists having the knowledge, skills, and training to contribute meaningfully beyond mere dispensing, traditional dispensing. Please, next slide. The overall perception versus satisfaction. There's a high-level view of how healthcare workers review the oncology pharmacy department. The positive sentiment here is that 91.3% have a positive overall perception, and 82.6% reported high satisfaction with oncology pharmacy services, while the contrast is that there's the poor perception group, that's 8.7%, and low satisfaction group, 17.4%, often cited the clinical gaps, which are ADR management and safety protocols, which are the reasons for their low rating. So the key takeaway here is providers are looking for more active clinical evidence in the ward. They want us to come more in the ward and interact with them. Thank you, Famtikari. Next slide. The barriers to effective collaboration. Here are some of the barriers to effective collaboration. Most of the healthcare workers, they pointed at communication gap. But communication gap is 26.1%. These are sort of ineffective communication, lack of dialogue between departments. Then there's also resource shortage and institutional hurdles. That's manpower shortage. At times when you go to pharmacy department, you find out that they only have like 2 oncology pharmacists trying to settle new patients, trying to reconstitute. So the workload can be actually much. So the actual contribution of oncology pharmacists can rarely be felt. And lack of clear clinical protocols, which account for 13%, also hinders the ability of pharmacists to provide specialized care. Next slide, please. Voices of the healthcare workers. There are various suggestions by the oncology healthcare providers. They need more training and specialization. They need more specialized oncology pharmacists, which account for 1.7%. They're also eager for improved communication and collaboration, which account for 17.4%, increased staffing in order to reduce workload, to ensure drug availability. Most of the cancer patient and healthcare providers are really frustrated when it comes to stock out. And also they complained of 24 hours availability of oncology pharmacists. Most of the oncology pharmacists close early, and at night when their services are needed, they are nowhere to be found. Then provide adequate facilities. Some facilities that offer oncology services don't even have a clean room, a biosafety cabinet. So this has to be looked at. Then also policy and government support, then full participation in the MDTs. Next slide, please. Strategies for change. That's, we need to enhance our visibility. We'll now talk about active integration. Pharmacists must move beyond the pharmacy unit to participate consistently in ward rounds and MDTs. Also, we need to introduce ourselves. They said we need to blow our trumpet ourselves. We need to use standardized materials like bulletins, posters, brochures to define the pharmacist's clinical roles to other staff. Most of these other healthcare providers don't really know what we are supposed to offer. So we need to blow our trumpet ourselves so that they can understand from where we are coming from. Next slide, please. Next slide, please, from Tikari. Hello. Okay. We need to
I'm on the
focus on
next slide.
ADR. Okay, thank you, Ma. Thank you so much, Ma. We need to implement a structured ADR monitoring and reporting system led by pharmacists. Some hospitals don't even have a pharmacovigilance committee or an ADR team where these challenges can be channeled to. So we need to have pharmacovigilance committee and ADR teams in our settings, and also take the lead in developing and auditing safe handling of cytotoxic. Next slide, please. Also, there's this saying that people normally say, anything that is not documented is not done. So we need to integrate records. We need to ensure pharmacy clinical interventions are properly documented in central patient medical file. Yes, most of our centers have pharmaceutical care forms, but it has not been integrated properly into the system because most of the times they are not being looked at and they are being removed from the patient's medical file. So we need to see how we can integrate the pharmaceutical care form into the patient medical file. And all interventions need to be documented properly. Then also open channel. We need to establish dedicated communication protocols where specifically consultation hours or digital messaging for immediate healthcare providers query. Here, the drug information centers can come in, where if there's any query, it can be channeled towards the drug information unit and can be attended to adequately. Next slide, please. Strategies for change, that's capacity building. Pharmacists need to specialize. We need to specialize in oncology. I could remember when I was trying to specialize in WAPCP, we were just 3 that were specializing in oncology. Other specialty had 50, 60 students, but we're just in my own set, we're just 3, one from Kasena, from Sefula, and pharmacist Oluwatosin from Lagos. So we need more pharmacists to specialize, and also need institutions to sponsor and train more pharmacists in oncology. And also scholarship can come in here too. We need more scholarships and we need more training for pharmacists that want to specialize in oncology, because most of them, they'll tell you it's quite expensive, but we can do more by sponsoring our pharmacists. Peer-to-peer education, host brief clinical launch and learn session. We need to build relationships with the doctors and the nurses. We need to really build relationships with other healthcare workers so that we can be recognized fully. We need to create launch and learn sessions for nurses and doctors on new chemotherapy agents or drug interactions. Next slide, please. institutional suggestion at policy level, standardized protocol, collaborate with hospital management to create clear written protocols for pharmacist-led adherence support. Also, we need our pharmacists to be lead procurement strategies to prevent the drug syndrome, that is stock out. The HODs need to be involved in they need to be part of the procurement team so that we can avoid the drug syndrome that frustrate healthcare workers and patients, because most patients, one of their major challenge or concern is with stock out. Next slide, please. Next slide. The future for oncology pharmacies is patient-centered care, moving from a dispensing focus model to a more clinical care model. The patient, as in high patient satisfaction, the 5.2% prove that patient wants this interaction. They want us to come to them. I could remember a patient when I was trying to collect my data. She was like, they tend to learn about their side effects from their colleagues. The pharmacist really had time. Maybe it's just their first visit, you had to interact with them, but subsequently about side effect management and other complaints, they discuss it more with their colleagues. They learn more from their colleagues. Those that have been into the chemotherapy, they're on chemotherapy for a long time. They tend to learn some of this side effect management, some things from their colleagues. When with this, if the patient are satisfied, healthcare workers' perception will follow as clinical outcomes, by the grace of God, will improve. Next slide, please. Call to action for oncology pharmacists. So we need to shift the poor perception among the minority and improve the quality of services, increase clinical visibility, that's transition from the pharmacist unit towards MDTs to address the 30% of providers who rarely collaborate with us, lead on ADR. Since only 39.1% of healthcare workers felt pharmacists manage side effects effectively from the raw data, taking ownership of chemotherapy toxicity monitoring is our most powerful tool for changing perception. Then standardized communication, formalize how we communicate our interventions so they aren't lost in the communication gap. Conclusion. So my conclusion here is that healthcare providers recognize oncology pharmacies as essential, but underutilized and under-recognized in direct clinical management. Poor perception are largely driven by communication gap and lack of clinical visibility, but by focusing on ADR management and multidisciplinary integration, the cancer space for pharmacists can be significantly expanded. Next slide, please. Open for questions based on personal experience and dissertation findings. And thank you for listening.
Thank you so much, Ram Hassana, for sharing your
Thank you.
study. I encourage you to share this study because I wanted us to see in reality what the situation on ground is. Maybe to help us to put in the work and then do the needful. Thank you so much.
Thank you,
This
Ma,
is
for giving me
actually,
the opportunity. Thank you so much for giving me the opportunity, Ma.
you're welcome. So this is time for question, comments, and suggestions and all that. If you also have questions for the first presenter, she will answer. You can also share your experience as regards MDTs and all that. Please, this aspect is very important for oncology pharmacists. You cannot work alone.
Hello, good morning,
You
ma'am.
need to work. Yes, please. Good morning.
Yeah, good morning. Good morning, ma'am. Good morning, all our presenters. I'm Balem from Spain. I'm live from Africa Medical
Yes.
Center of Excellence. So, what
Yes,
we
Famsani is
intended
part
after,
of this team. Thank
yes,
you.
yes, so what we intended after the presentations, then we come with what is obtainable in our society, in our community. So that we should know that truly what we are saying is practicable, is obtainable, and let's aim towards for better improving what you call it, our practice. Can you hear me?
Yes, we can hear you. Although it's
Can hear
cracking
you.
small, but we can hear you.
Okay. So let's start with the issue here where we practice actually pharmacists, especially clinical pharmacists. When we say clinical pharmacists here, we refer to oncology pharmacy. They are part of MDT. So we have to be there before we start MDT. If we're not there, they'll give you a call and make sure that one of us were there at session table. So when you come down, when it comes to medications, so you actively involve yourself in choosing the regimen, making suggestions based on the patient's specific data. Then we come to chemo verifications order. So after the drug has been prescribed or regimen has been prescribed, so it's sole responsibility of clinical pharmacists to go and do homework, ranging from drug interactions that you talk about using Netscape, calculating the dose. Nobody will do it for you. They only give you weight and the height of the patient, and they look at patient profile. Then you go and check for the patient's what they call it lab, where you at every visit you are responsible to check for the patient's fitness to go for chemotherapy or otherwise. And you are the best person there to suggest what course of action are you taking, whether this patient actually needs GCSF. So if the patient is taking weekly chemotherapy, you know which one are you recommending. Um, in contrary to the patient that is taking 3 weekly chemotherapy, so you cannot come and start saying this patient should take filgrastim or take filgrastim. You have to have a fact. If patient is taking weekly treatment, you know that okay, this patient is on filgrastim. So you suggest, and based on the lab value that you have and interpretation, you check at every visit that once you see neutrophils are going high, so you check ANC, then you recommend that this filgrastim can be what you call can be with health with this cycle. So tending to the next cycle for your visitation. Then it's our responsibility so that to look at dosing, like there is what you call dose tracking. When you're doing dose tracking, like when you are dealing with carboplatin, after calculating the dose of carboplatin, you realize that the EGFR, because we are using GFR of the patient to calculate the carboplatin, sorry. So once you realize that the patient GFR is above 125, so you always cap the dose at 125. That is the maximum the patient can take because you can have patient that is obese. Sometimes you can calculate the dose of. So when you say the dose, the maximum dose is 125. What it means is that either you have two ways of giving carboplatin. It's either you give it weekly, you can use AUC either 2 or 1.5, or you're using 3 weekly, using AUC from 4 to 6, 4, 5, and 6. So based on that, you can be able to say, okay, based on this is a decision. So you write it under comment. This is your responsibility as oncology pharmacist. And the other drugs that we don't turn away from. Vincristine. Vincristine, we have a maximum dose of everybody knows about it. Having dose is 2 milligrams. So you can have so many patients that when you calculate that you see okay, you already have the BSA2. So by the time you have BSA2 and the dose is around 1.4 to 1.5 milligram per meter square. So you realize that you already exceeded the 2. So you carry it at 2 and you put it under a comment that this dose has been capped at this, so that you have a backing. And another thing is that you have to put it boldly that in red, when you are giving carboplatin, when you are giving vincristine, to not give intrathecal, it is fatal. So you have to put it with caution. This is all our responsibility as a pharmacist. So if we are bringing something to the table, always they will see the relevance in us and like what all the presenters have been saying, and you need to document what intervention have you made. So once you come to MDT and you are reserved, by thinking that I will not go to MDT because they will not ask me the question that I know, always come prepared. There's room for learning. If you don't know, yes, yeah, you don't know, but you can find out and come up, you come stronger when next you are coming. Then we look at other drugs like those drugs that have lifetime dose, like doxorubicin, daunorubicin. You know, they will tell you that you cannot give more than 450 milligrams, 450 to 550 per meter square of that drug. So it's very important that because sometimes they will prescribe a drug like in some of the patients that you see them, they're taking R12, those patients that have myeloma patients. So you need to be cautious always when you are dealing because you have to ask them that have you taken this drug in another center before coming to your center because you realize you see these patients that will be on this drug for 8 cycles or so after they have took it in the past. So you always need to put your eyes. That's the one they say that okay, you know what you are even doing. Because these small things, we just take them for granted and it will go unchecked. Because these drugs are all drugs that they have toxicity. Then we go into medication switch. Sometimes they will call you. Actually, we have a patient that's already on formulations like bortezomib. This patient is on substitute and now they have a side effect that this patient is not tolerating the drug. What do you do? If you are responsible, you need to find out that okay, some of these drugs you can actually switch from their substitute to IV so that some of the side effects can be minimized. Like all these drugs, like you can see, like sometimes you see that in their regimen, you see that they're switching thalidomide with cyclophosphamide. You need to know why. Like the bortezomib substitute with the bortezomib IV, all in attempting to mitigate one or two of the side effects. Then you check for medications. It's very important. When you are checking your lab value, know what it means. Like when you are seeing all these sodium, potassium value are low. So sometimes you need to go for corrections. You need to advise for let's correct this potassium level, let's correct this electrolyte before even giving the chemotherapy because they actually affect them. Sometimes even the post medication, you advise on switching. Like in case of where you have sodium or potassium are low, you don't give rabiprazole as their post medication, you give ranitidine. So in that case, it will show your relevance. So whenever they prescribe drug like zoledronic acid, the next month, always ask for the serum calcium because you realize that the majority of this result that you are obtaining, when you come to the lab value, electrolyte, urea electrolyte, you usually see calcium is omitted because you have to send the test separate. So you always ask the calcium level before prescribing the drug or before administering the drug. Then another role that we should face that is what we call medication chart. Like majority of our speakers are talking about that. You realize that you see patients with prescriptions apart from chemotherapy drug, there is other comorbid drug that is taken. You see antihypertensive and diabetic and sort of drugs like all these iron supplements. And when you are reviewing these patients, usually hematology patients, you see them that they are on several what do you call it, post medication, so which are related to some of the side effects of this drug. You see them on several antibiotics, what do you call it, blood, what do you call it, bonds, supplement, and what have you. So one of your responsibility here, oncology pharmacy or clinical pharmacy, you design a chart that okay, this drug will be taken for 1 week. So you design your chart. That's what we call medication chart. Maybe for paraben. So if you come to our facility in one of these hands-on training, we will show you detail of what we do. Like you see it with your hand that okay, how do you design medication chart? Whereby okay, this drug should be taken, let's say the patient is on main drugs is taking like let's say thalidomide is for 21 days. You design your chart. Okay, he's taking bortezomib every weekly, or he's taking it day 4, or day 1, day 4, day 1, day 4, day 7, day 8, or day 15. So in that order. So you have to design a medication chart, a cycle, and this patient is taking other drugs. You all put them in the chart. That okay, you are given a key. Okay, this one is taken for 7 days. Then you indicate this one is for 14 days. Indicate this is for 21 days. Indicate you give to patient. That will help you that to track the subsequent treatment for the patient. Because usually when you give them chart, you communicate with your health record. Like this patient will be put on alert that okay, in when you're coming treatment in 2 days, you have to come and do your lab because before you even come to the facility, you need to check your value and check your lab and ensure that they are within the acceptable range for your next chemo. So you don't have to when the patient comes then after the patient has already made his mind, maybe he has taken excuse from his place of work. Then when you by the time you arrive at the facility, then you start telling him that okay, sorry, we have checked your value now. We realize that you cannot take this chemo. You can go back and come back when you didn't treat. So at least you have reduced the burden to the patients. Then another role is that why is this matter to us? All our role that we're talking about, all that we have been discussing from the beginning of our lecture from day one today. Why is this important? One is for safety. That's what we advocate. We are all looking at patient centered. Then the safety of patients is of paramount. Don't forget about even the safety of patient. Your safety is important as the safety of patient is paramount. So does that mean you cannot be what do you call it? You be overemphasizing on the safety of patient, while you are neglecting the safety of you as a professional and other professionals that are working within the facility, ranging from the cleaners, other healthcare professionals that are working. So then the other patients, we are all looking at their safety. That's why we are all advocating on this oncology pharmacy to be integrated. If there's any center that we deal with that as what do you call it, orphan, we need to pay a visit, and if need be, we give them presentations on the need to state of oncology pharmacy. Then where to start? If we didn't start, so how do I going to start now with my facility? Firstly, you need to make a short presentation based on what you have gathered. All you need to do is just present about safety. These drugs are hazardous. So the safety should not be overemphasized. If you can be able to defend your 10, 15 slides before your department, let's say, okay, in one of your departmental presentation, it's not always about clinical. Now let's come and talk about hazardous of chemotherapeutic agent and the route to which you can take this hazardous drug, either through skin, inhaling, or any of these. And this hazardous, you can be able to emphasize that it's not something that you see right there and then. It's accumulative, so that they will take it serious. So let's be all what do you call ambassadors of all this. So must I have my safety cabinet to start oncology pharmacy? This is the questions that I'm going to throw to the house. Thank you so much. We actually have a very vibrant and energized chairperson. We thank you so much for all you do from the recap in the morning to every day and right timing and giving all the opportunities. Thank you so much.
Thank you, Famsani. Famsani is actually a member of the team that presented the topic today. He is the third member of the team from AMC Abuja. Thank you for sharing that, your experiences. If you listen to him very well, you will notice that he is speaking from experience. He's sharing his experience. He's trying to encourage us that in your bid to advocate for inclusion into MDT in your center, you need to make presentations. The power of presentation: during your hospital seminar, prepare a presentation on ChemoSafe. Educate the hospital on why they need to have central reconstruction room, why they need to have biosafety cabinet, why they need to stop bedside chemotherapy reconstruction in your facility. In my facility, the last presentation we did, because when we started, hemato-oncology unit, they were still doing their own, every other unit was working with us, gynae oncology, surgical oncology, and others. But hemato-oncology felt that they want to do their thing, their own chemotherapy in their ward. I left them because I don't want to fight so many battles at the same time. We decided to secure the others first. When we finish, we can now face them. But when we did that presentation, during the presentation, the registrars, the nurses in hemato-oncology, they said no, that they don't want to be doing chemotherapy again. They did not know that this thing is dangerous like this. By the time we finished doing the presentation on ChemoSafe, in fact, the next chemotherapy day, they shifted all their patients to us and said, please do the reconstruction, and you and the oncology nurses take over they handed over everything to us, and they said they don't want to do again. That is the power of presentation. So please, do a presentation on MDT, adopting MDT approach for cancer care in your center. Choose a date. I know hospitals, they have a day they do hospital seminar. Present it on educate your management, everybody in your hospital, and you will see things will change. That is what Famsani is trying to say. I don't know if there are more questions. Is there anybody with contributions or questions again? So we can round up. I think we've tried.
Hello, good afternoon, ma. Good afternoon, ma. I want to say
Good
something here.
afternoon.
Yes, ma. Please, ma.
Go ahead.
Most of us find ourselves in secondary facilities. Some of us are in community facilities, and we have the passion for oncology, and apart from the WAPCP, the going for ward rounds and all. After WAPCP, how can we incorporate ourselves? Because it's only in tertiary facilities you would have ready, you can always go to the ward, visit patients, but since we are not working there, we don't have that access to always go there. So please, how can you advise us, please, ma?
It still boils down to what I'm talking about.
Okay.
Awareness. See if you can do a seminar for your facility. Do they do hospital seminar in your facility?
Yes.
Are they doing bedside reconstruction in your facility?
I work in a secondary facility. We don't see oncology patients. If you want to actually interact or see oncology, you have to go to the tertiary hospitals like National Hospital, FMC Jabi,
Okay, so
Gwagwalada.
they don't manage cancer at all in your facility?
We mostly refer, yes. If they come, we refer to these facilities for proper care. I was only told it's the only secondary hospital that sees oncology patients in FCT is Maitama. And at the end of the day, they still refer to tertiary hospitals. So because you cannot just go to National Hospital and say you want to start coming, you have to write, they need to approve for your coming. So I don't know. But what my
Except you want to
supervisor advised, what he advised was I should write through my HOD, through my MD, that I want to be coming for hands-on training in National Hospital so that I can have access. So that was what he advised. But I want to hear from your own perspective, ma.
No, what he advised is possible.
Hello, ma.
If you write. I'm sure. Hello, can you hear me? Has my network started again? Can you
Yes,
hear
ma, I
me?
can hear you. No,
Okay,
no,
I
no.
said
Yes,
what your
ma, we can hear you.
Okay, thank you. What your supervisor advised is actually possible. I didn't know that they don't handle oncology cases in your center at all. It means it's not your own case is actually different. The issue is that the patients are not there for you to even go to the ward to see. Do you understand?
Yes,
So
ma.
it's not as if they are preventing you from being included in the MDT in your center. No. It's
No.
just that the practice is, you don't have that oncology care practice there in your center. So you need to, if you still want to be in oncology, to reach out to another center.
Yes,
So
ma.
what your supervisor advised is in order. You need to write to the closest facility near you, if it's National Hospital, so that you will be able to come in maybe as a volunteer so that you will not forget what you've learned so far, because if you don't practice for a long time, you begin to forget everything you've learned. Even for oncologists, I know so many oncologists that come to Calabar Cancer Center. I'm talking about radiation and clinical oncologists. When I interacted with most of them, they told me why they are coming all the way from Abuja, from Jos, from Port Harcourt to Calabar is because they don't have radiotherapy machine in their center. And as a radiation and clinical oncologist, if you don't practice for a while, you will forget everything that you learned before. So they come every week, one different oncologist. That's how they do it, to come and keep up to date with their practice. So I think that's what you need to do. Find a center near you where you can attach yourself. That's the only way you'll be able to practice. So
Okay, ma.
we can
Thank you
see,
so much.
you're welcome. We can see some hands up. Ramatu, please go ahead, ma'am.
Good afternoon,
Hello, ma'am.
everyone.
Yes,
Hello, can you hear me?
yes, ma'am, we
Can
can
you
hear
hear
you.
me? Okay, good afternoon,
Yes, we can
everyone.
hear you.
Yes, good afternoon, everyone. And it's been a long day, and I appreciate all the facilitators, all our facilitators for today. And when you have facilitators without listeners, your work is zero. Let me appreciate all the listeners that have been on the call since morning. It's actually showing the level of passion that is building up in some pharmacists, for oncology pharmacy. And today, let me say this, that I am very happy, since I have joined this morning, because some of us that started, just like the chairman has been saying in the morning, since 2011, 2012, and putting ourselves together to say, okay, today this is open as an association. I am happy because I kept on saying oncology pharmacy has come to stay in Nigeria, and it will not die. So first of all, let me talk about regulation. In 2021, this same chairman said they wanted us to come and talk about specialization in Port Harcourt. And she called me and said, Ma, I think you will be the one to come and talk to PSN about this. So I want everybody to know that, number one, PSN right there, after all of us, myself and Jacinta made presentation, that is a canvassing for specialization in all fields, specialization of pharmacy in Nigeria. They gave us the go ahead, and that has been gazetted that pharmacists in Nigeria can now go ahead and specialize, in whichever, areas that they want to specialize. But secondly, they went on to say that the only way is that pharmacists should please go for postgraduate studies, meaning you cannot, from your BPharm degree, just become an oncology pharmacist. But because oncology pharmacy is something that is pretty new in Nigeria, we all agree that you can become an oncology pharmacist even undergoing tutelage, undergoing, mentoring from some other older colleagues. But the best way is now you finish your BPharm and then go to the West African Postgraduate College of Pharmacy. And that one was actually approved. And that was why the West African Postgraduate College of Pharmacy have, and that is why they started these postgraduate studies and these specializations. When we first started, of course, even up to today, the students in the West African Postgraduate College for Oncology maybe like 10, In fact, as Anna said, there are just 3 in our own class. For me, I know I wasn't bored. Somebody said, and you would think you want to go ahead and lecture only 3 people. I said, yes, I don't mind. If it is the only one person in that class, I will go ahead. Because what we need are field soldiers. And that's why I said today, I am happy seeing Asana talking, seeing Sani Abdullahi come out and talk, So we are all happy. So I want to encourage all of us that it is we that will change the perceptions of even our hospitals, where maybe the HODs or our leaders are saying we do not want to, where you are trained as an oncology pharmacist, but they will carry you away from the place and come. Just like what the chairman has said, all we all needed is just to be patient. The narratives are changing, and it will continue to change as long as we see oncology pharmacists that have passion, and as long as you know that patient-centered care is what you need. The cancer patients, for them to get the best is what you need. Of course, there's nothing like working without your stipend or without your allowance, being attached to whatever you do. But keep the flame burning. That is what I want to advise everybody. Keep the flame burning. And please, you have been mentored. please, you that have been mentored, please make sure you too have some other mentees. So that way, through mentorship and through encouragement, in my own hospital, I will tell you that some people, Suleiman and Nafisa, deferred. People have gone to that extent to make sacrifice. They said we want to specialize in oncology pharmacy, and it is not starting this year in postgraduate college. And they were already in the college. You know what they did? They said we are not writing exams this year. We are waiting until oncology pharmacy started. Even already, they're already in the clinical pharmacy. But we want to come out of the college as a specialist oncology pharmacist, you know. And so they waited for college to start, you know. People had made that sacrifice. And I'm very sure the narration is changing. And I want to encourage everybody, you know. In the olden days, some 15 years ago, there's nothing like oncology pharmacy in Nigeria. But I said I'm happy because I can see a lot of people talking here today, and over all the workshops that we have had with WAPCP, you will see the passion. And I'm happy because I know that by God's grace, oncology pharmacy has come to stay and is not going to die. The only thing we all continue to do is to improve ourselves, you know. The practice might be better in one center, you know, more than the other center. Please let us still continue. And for the person talking about, I am not in a tertiary institution, I am in a secondary facility. It depends. If your secondary facility sees cancer patients, you attach yourself to those doctors that are managing those cancer patients, because it is not all centers that will refer. I'm telling you, it is not all centers that will refer to specialized oncology centers. Some will still be doing their own, you know, small, you know, by the side. So you identify yourself and make yourself known to them. The chairman has already told us that please, we should go and make presentations, you know. Already talking about chemotherapy safety alone if you do not have, please talk to all other pharmacists. There's a chemotherapy safety booklet, a policy that has been launched in Nigeria. Once you get that one, you can now set up and talk to your hospital community about chemotherapy safety. That has changed the narrative for some of us in our hospitals, you know, and that is what they are telling you, so that we can change the perception. We know there's still a lot to be done, but I still want to tell you that they say Rome was not built in a day, you know, it started gradually. If some of us said, oh, this thing will not work in Nigeria, and we fold our hand, there will be nothing like oncology pharmacy in Nigeria today. But gradually, successive pharmacists have been coming now, you know, making impact and making the little inputs that we can be, that we can do. And the thing is going, you know, it's already spreading. So I will encourage the listeners, our listeners today who are undergoing these workshops, to know that they are still field soldiers. You are field soldiers. Whatever hospital you are, whatever community pharmacy practice you have, even though, of course, you cannot give chemotherapy in your community, but please find a way to make yourself useful in any place where you find yourself. That is my advice. And please let us keep the flag flying. And oncology pharmacy has come to stay, and we will continue, because as long as there are cancers, oncology pharmacists will always have one work or the other to do, and they will improve the outcomes of all our cancer patients. So thank you very much. That is just my little bit of a contribution and encouragement to all of us. Thank you.
Thank you so much. Thank you so much. That's from Ramat Alebewele. She was the pioneer chairman of OPAN. She handed over to me. Thank you so much, ma'am. We are trying to continue the tempo from where you stopped. What she mentioned community pharmacists, and she said that you should try to be useful where we are. I want to tell all of us that there is a role for community pharmacists to play in cancer care. And that is one of those roles is serving as clinical patient navigators. It's a new thing, you know, we are trying to design studies around that so that we can make it more, known to community pharmacists that there is a role for them. If you notice during the MDT, the Pamtikara mentioned navigator. The navigator she was talking about that time, she was talking about what we call physical navigators, those that move patients around from one place to the other. There are 3 types of navigators in cancer care. You have the clinical navigators, that's where the oncology nurses, oncology pharmacists, the community pharmacists, they play their role as clinical navigators. Then you have the resource navigators. Resource navigators are those in social welfare, those that, you know, arrange interface with NGOs that sponsor cancer care and all that. Then you now have the physical navigators. Those are those health assistants that help with wheelchair to move a patient to maybe to the internal medicine unit to do echo, move the patient to the lab to collect samples, you know, move the patient to the ward and all that. So there is a place, there is a role for community pharmacists to serve as clinical navigators. This is not the forum to discuss more about that. I just want to mention it. So we still have some hands. Dr. Williams, I saw your hands up. Please go ahead. We need to round up so that people can go. And please, hello, ma. Go ahead, ma.
Yes. Good afternoon once more. I want to commend the pharmacist Hassan for that beautiful presentation. It takes courage, despite in the hospital, to go into research. There's an observation I want to point to her later why she's making this presentation. So, Farm Asana, please reach out to me. Thank you.
Okay, ma. Thank you so much, ma.
Thank you. Farm Hassan, I hope you submitted abstract for the conference. And there's
Yes.
a 090. Can you go ahead, please?
All right, thank you very much, ma. So thank you once again for all your efforts. I'm so grateful for this training. So my question now is concerning the West African postgraduate, the college. So the sponsorship for someone that wants to maybe embark on such journey. One of the presenters made mention of that you can get sponsorship or scholarship, something like that. So I want to know how this can be achieved, especially because I know why most of this, or most of us, or most pharmacists don't want to go on such journeys because of the cost. The cost is on the high side. So if there's a way that the bills will be reduced for us, I think most people will try and venture into such a program. Thank you.
I want to understand your question. You said sponsorship. I don't understand the question. You said
Yes, like
you're asking about
scholarship.
sponsorship. Oh,
Yes, if
scholarship
yes, scholarship.
for fellowship program.
Yes, because I believe why most pharmacists are going back, like they are not entering into the program, is because of the cost. So if
Because of
it's a
funds.
bit subsidized, you see that
Wow.
most people would try to enroll. That's what I wanted to know, if there is any room for scholarship. Thank you.
For the college. For now, I'm not aware of any scholarship in West African College. I know that the college is even, you know, struggling to raise funds for most of the things they do. You know, even the preceptors, the supervisors, they are not really being paid well for the work. They are doing it out of, you know, how do I put it, a passion for the profession. So I will allow the college to speak. I'm not a member of the college. The faculty secretary is here. Dr. Telma, please, can you comment? Professor Odili was here. Has he dropped out? Dr.
Please,
Telma, please, can you comment on?
yeah,
Okay.
from IJ, can I just add a question, additional thing that I would also want the college to think about very quickly?
Okay, sir.
Okay, I'm here from Ijoma.
Okay,
But
thank you, ma.
after the speaker, yes.
Okay, okay, thank you.
Do I go ahead?
Yes, go ahead, sir.
Yeah, considering the fact that several of our pharmacists, both even the younger ones and the middle-aged ones, are now getting so much interested in cancer and now want to be role players in different areas of their practice. Sometimes leaving your facility to the college might be a challenge and all that. And in this era of IT technology, I am asking if the college can design an online program, very strict online program, and possibly a hands-on training in a facility, a tertiary facility close by, where we have accredited oncology pharmacists that will be able to supervise the hands-on training, which to a large extent will increase the pharmacy workforce in this area of specialty. So I'm just thinking in that line, because sometimes moving down to the college to be physically present based on the tight schedule of work in our respective places of practice might be a little bit a big difficulty. I'm just thinking aloud. Thank you.
Thank you, sir. Dr. Thelma, before you come in, please, let me just say something so that you can now summarize. Dr. Zia, thank you for that question. I want to let you know that all your demand is already what we have on ground. The fellowship training in West Africa is online program. The lectures are online. It's only the exam that is physical, and there are centers in almost all the geopolitical zones. There is a center in Enugu. So if you're in Enugu State and the environs doing fellowship in the college, your lectures are online. It's only during exam that you go to Enugu to write the exam. Then as per the hands-on training, there is the fellowship training in the college is residency training, like for oncology pharmacy is residency training in oncology pharmacy. What it means is that you have to do 1 full year residency in oncology in a facility where they have functional oncology pharmacy. So in your part 1, you're doing 1 year residency program. And also in your part 2, you know, the fellowship training is a 5-year training program. You have your 1 year of primaries. And then when you pass the primaries, you enter the part 1. During your part 1 is 2 years. You will do 1 year residency training. In a facility, you have a preceptor that is approved by the college that will oversee your training, your residency at that center. Then when you pass your part 1, you move to part 2. And in your part 2, you also have 1 year residency training in a facility that is approved. And you will have a preceptor in that facility. And you also, in addition, do your dissertation. You will have a supervisor for your dissertation. So what I'm trying to say is that you don't need to go physically to the college. No, the college programs are already virtual. It's the exam that you write in centers very close to you, but your residency training has to be in an approved facility near you. So, Dr. Thelma, over to you, please.
Thank you so much.
Yes, sir. Dr. Thelma, are you here? Hello, ma. Is Dr. Onodugo still here? She was here. Did she drop out? And Professor Dili was here too. Like he has dropped out. Okay. Dr. Thelma, are you there? But I believe I've answered the question to the best of my knowledge.
Chairman.
Okay.
Hello.
Yes, ma.
Yes, I just want to say something about scholarship. Maybe they don't understand what the person meant. Actually, when you work as a pharmacist, maybe in your own facility, the scholarship, I think part of the scholarship that person meant is you write to the management of your hospital, you know, and ask for a form of sponsorship that you want to go for a postgraduate study. You get it? So maybe when you write to the management of your hospital, now the management of your hospital will now give you a form of assistance, financial assistance for you to be able to attend the college. Some tertiary institutions have done that, for their pharmacists. So that is one form of scholarship or sponsorship that you can get. But it's not as if maybe the college or some association like OPAN, that is just coming up as any scholarship that is being given to anybody right now. But in your institution, you can write that you want to go for a postgraduate study, and maybe the management, you put yourself together, maybe the management can decide, okay, we would assist you maybe with 50% of the cost, and then you can now put 50% of the cost. I know some pharmacists have done that in Nigeria for them to be able to go through the postgraduate college. I'm so sorry that things are just getting expensive these days.
Thank you. Thank you
And
so
that was
much.
what I actually meant. Or maybe a rep can as well help out, like maybe companies or something.
Yes,
It's not like
companies can sponsor. Yes, but it's you that will apply to them. It's not the college. It's you that will apply to companies for sponsorship and your management for sponsorship. So earlier somebody was asking about pediatric oncology subspecialty, because I mentioned it when my colleague was asked a question. I was trying to say that in as much as they are yet to post her to my unit, that what I did was to get her to start building her capacity in subspecialty of oncology pharmacy, which is pediatric oncology. So the person is telling me that she is interested in pediatric oncology pharmacy. Okay, pediatric oncology pharmacy, like I said, is a subspecialty of oncology pharmacy, because you know that in pediatrics, what we have is that most of the clinical trials, most of the new drugs, the clinical trials were done with adults, not with children. So you will find guidelines for managing these cancers in adults and not in children. So in pediatrics, there's a lot of technicalities you need to, maneuver and all that. So it needs, is a subspecialty that you really need to build your capacity before you can enter. So what happens is that you have some guidelines like PSYOP guideline that they use, but it doesn't cover all the cancers. And sometimes you see a cancer that the regimen is completely. Oh.
Sorry, am I the only one that can't hear her?
I think the network
I
is
can't hear
fluctuating.
again. The network just went.
Yeah, she'll come back.
Please forgive me. Hello, can you hear me? My network threw me out. Hello, can you hear me, please?
Yes, ma'am, we can hear you.
Thank you. Forgive me and my poor network. So please, there is a PSYOP conference coming up. This year's PSYOP conference is in Nigeria, and it's coming up in April. I've posted it on the training group, April 13th to 15th or so. So if you are interested in pediatric oncology, please try to attend that conference. It's in Lagos this year. And there is actually PSYOP Oncology Pharmacy Group in Nigeria, and they are working on developing the curriculum for training pediatric oncology pharmacy. So there's a lot of work going in. So if you're interested, you can reach me and see how we can add you to the group so that you can start building your capacity in that subspecialty. If there is no other comment, we'll talk about the next session. The next session will be coming up on 10th April. 10th April, and we'll be discussing pharmacology of systemic anti-cancer therapy. We've heard so much about chemotherapy and all that. So please make sure you join us that day so you hear it in details. And it will be handled by pharmacist Salewa and Shaba and their team. So please join us again on 10th April. I don't know if the college is here to make a comment before we round up. Dr. Thelma, are you back? Please, I hope everybody has done the attendance. They posted a new link. You were complaining earlier that they...
I'm
Yes, ma,
here.
you... Okay, please, I've been
Hello,
calling
Mama
you to...
Sijama.
Yes, you can now make
Hello.
your comment, please, so that we can finish. Ma, go ahead and make your comment.
You are breaking.
Okay, go ahead, ma.
Hello.
Go ahead. Yes, ma, go ahead.
Yes. Yes. I don't know. Am I supposed to say a remark or something?
Yes, there was actually a question for the college, but I think I try my best to answer. From Rama to support it too. So I believe we've
All right.
answered their question. So, but you can make the final
Okay.
remark so that we can close for today.
Oh, okay. So, I want to say thank you to all the participants and the organizers. Yesterday, I think I couldn't join. I don't know of the Dr. Chine and Professor Val. We had another workshop that was happening at the same time, and we're presenting and facilitating as well. So I want to apologize for that. And I want to ask that those who are yet to complete the attendance form kindly do that, especially because we need your official names as you want it on the certificates captured. The names that come along with your registration numbers are just the ones we got on WhatsApp. So let us have the official names. Oncology space is growing increasingly, and I think it's the best step that you are taking to get yourself certified and more knowledge on oncology. I want to say that there's a growing space, like someone mentioned the psychology of it. So there's something called psycho-oncology. And I want to entreat all of us, whenever there's an opportunity that the college and OPAN is organizing any form of workshop or certification, you should enroll. And it's sequential. There was one in October, and this year we are having a pre-conference webinar. Like Pharmacist Ijeoma spoke about, 10th April again. I will entreat that you all follow. And if you miss out, you are actually going to miss out on a lot of information and current trends in terms of best practice when it comes to the oncology space. So let's take advantage of every opportunity that the college and OPAN has for certification or getting more knowledge out there. So I want to thank all of you and to thank OPAN especially for always carrying the mantle when it comes to the oncology space training and certification. Thank you and over.
Thank you so much, Dr. Thelma. Dr. Thelma is the faculty secretary for the Faculty of Clinical Pharmacy, West African Postgraduate College of Pharmacists. And I think we've come to the end of today's presentation. I hope that if you did not learn anything today, you've learned about multidisciplinary team approach to cancer care, and that oncology pharmacies have, a prominent role to play and a space in the MDT team, and that you should make sure that you're part of the team in your center. Thank you so much. See you next time, 10th April. Bye. Have a nice weekend.
Bye, everyone.
Bye,
Bye.
everyone.
Bye.